Then I think mostly I have done with all the introductions. We really welcome our speakers today. Professor, starting with the Professor Kirti Rekha Mahapatra, Dr. Abhishek Rath, Assistant Professor, Sri Jagannath Medical College, Puri, Dr. Chinmay Ratha, and Professor Subhra Ghosh from Sri Jagannath Medical College, Puri again, and Professor Lucy Das, she's from SCB Medical College, and Dr. Professor Ajit Naik from Balasore Medical College, Fakir Mohan Medical College, Balasore, and so Mr. Saroj Panigrahi is the RMNCHA and N consultant of the state NHM, and Professor Sweta Singh from AIMS, and Professor Lata Chaturvedula from JIPMER. Lata will be joining a little late because she's got an examination going on. That should join a little late. So as and when each of the speakers comes, we can introduce in detail the speakers. Then finally, we will have the topics, of course, all of you know. Dr. Kirti Rekha Mahapatra will be dealing with the definition and WHO classification of stillbirths. And Abhishek Rath will be talking to us on major maternal risk factors for stillbirths. Then a very important session on fetal surveillance to predict and prevent stillbirth will be taken by Dr. Chinmay Rath, and counseling and investigation on repeated stillbirths, including RPL, will be enlightened by Professor Subhra Ghosh. Then we have a very important aspect which touched my mind when Dr. Meena Som of UNICEF, she wanted a referral protocol for preventing MMR and IMR. And this particularly referral protocol is extremely important for preventing stillbirths. So this Professor Lucy Das will be talking to us on that. And up to now, we do not have a state referral protocol that has come in place. So hopefully, when DFW joins and we have a referral protocol for the state, good thing. Then of course, role of birth companion in preventing stillbirth, a very short session I will take it. Then if there is a stillbirth, an IUD, morbidity comes while dealing with such cases, right from a 28-weeker to a post-term baby which is dead. What is the method in that time? Stillbirth registry and reporting is extremely important, which Saroj Panigrahi will be highlighting. And then
mute
Sweta Singh and Dr. Lata Chaturvedula about their strategies in AIMS Bhubaneswar and in JIPMER Pondicherry, so that when we go forward, we can take important inputs from them. Then, of course, the way forward and concluding remarks will be given by our additional director, technical NHM, from all these inputs. And then finally, of course, this may be, hopefully this will be followed up by a technical group meeting for entire state, whatever has been done for the strategies and up for preventing stillbirths. Hopefully this webinar strengthens that, and we can take it forward. Now I request before Professor Kirti Rekha Mahapatra, please share your slides, and she will be talking to us on definition and WHO classification of stillbirths.
Thank you, madam. Respected Professor Sama Kanungo, my teacher, and coordinator of maternal health, and all the dignitaries from our state and outside the state. Okay. Oh, thank you, madam, for giving me such a nice topic. Definition and WHO classification. Definition of still bath. When all the age of viability, we are decreasing, but still in definition of still bath, 28 weeks is taken as the cutoff. Because when we take 20 weeks, the maximum of stillbirth which occur in lower and middle income countries, for obstetric reasons, these countries, they have taken 28 weeks as the cutoff. So to have an international comparison, WHO has changed its definition. A newborn of more than 28 weeks of gestation with no sign of life at birth. Or if the gestational age is not known, if the length of the fetus is 35 centimeter or more, and if these two are missed, then if the weight is more than 1 kg or more, then, and there is no sign of life at birth, it is called as stillbirth. This 22 weeks to 28 weeks, it is taken for international comparison and include those areas where the stillbirth is still defined as more than 28 weeks. But CDC definition, here pregnancy loss at or after 20 weeks of gestation is taken in this definition. They are further classified as early stillbirth, that is 20 to 27 completed weeks, late stillbirth, 28 to 36 completed weeks, and term stillbirth, 36 weeks or later. So, in a single slide, just I want to show, if it is 22 weeks, less than 22 weeks, there is no controversy, it is miscarriage. And if it is 22 to 28 weeks, still it is abortion or miscarriage according to WHO classification. But others, they take it stillbirth. And after 28 weeks, then term and post-term, it is stillbirth according to, for international comparison, according to WHO, we have discussed everything. And if it occurs, the death occurs before the onset of labor, then it is called antepartum stillbirth. And it occurs during onset, after the onset of labor, but before delivery, then it is called intrapartum stillbirth. And if it occurs within 7 days, the fetus is live born and dies within 7 days, that is early neonatal death. And this stillbirth, along with this early neonatal death, they are in the perinatal death group. This perinatal group I want to emphasize because in WHO classification, it has as the causes and this etiology, it is almost same for the stillbirth and early neonatal death. They have included this perinatal period, not only the stillbirth or before birth. So, what is the burden? Every minute, there is 4 stillbirth. And each year, 1.9 million stillbirth occurs in the world. And more than 5,000 women or families suffer per day. And to the disheartening one, that is 3/4 of all stillbirth, they occur in Sub-Saharan Africa and South Asia. Our country is part of this South Asia. And when you compare, stillbirth rate is minimum in European countries, and Sub-Saharan Africa, like Nigeria, those countries, they have the highest ones. But it's 1.6 in European per 1,000 total birth in European countries, whereas in Sub-Saharan Africa, it is 31.2 per 1,000 total births. It is too high. Difference is so more than 20%. And what is our target? Target is by 2030, less than 12 per 1,000 lower birth by every newborn action plan. And another thing is 98% of all stillbirth occur in lower and middle income countries. So what about India? No, India is the highest number of stillbirth in the world, that is 522,000 per year. And when you come to different states, madam has already highlighted, you can see the red areas on this area of this Odisha. Odisha is our highest in stillbirth. That is we are infamous that way. So, how to classify? For to classify the classification systems. It is very important because from this system, we can know which areas we have to intervene to decrease the still birth. There should be accurate capturing and classification. That is the first step, because most of the stillbirth, many of the stillbirth, they occur silently at home. They are not reported. We have to bring to the report to those things and better understanding of the causes. And everyone must be knowing unexplained stillbirth is very fashionable term. Whenever we talk of stillbirth, why there is stillbirth is unexplained. So we have to decrease this unexplained stillbirth rates. Otherwise, if you can't explain, how can we prevent? We should compare it within and beyond the countries. For that, we have increased the lower end of the gestational age to be 28 weeks, so that different countries, they have come under the same area, so that we can compare the studies. So classification system should be, ideal classification system should be that. There should be better continuum of care and preventing strategies and decision on policy making, which is very important to reduce this alarming increase in stillbirths. And for this, there are so many classification systems. Most of them are more than 80, and it complicates our problem. Like Kodak system in UK, Stockholm system in Sweden, Tulip classification in Netherlands, Perinatal Society classification in Australia and New Zealand, and Collaborative Research Network system in US. So many classification systems. They are doing well with that. But these classification systems, they need a lot of investigations, lot of sincerity from the group, and they need a lot of persons also. So WHO decided to come to a classification in which everything will be okay, all countries can participate, and this stillbirth can be reduced by different planning, which can be initiated from these classification systems. So WHO application of ICD-10, International Statistical Classification for Diseases and Health Problems, 10th revision during perinatal period. And then WHO working group, it was taken from some obstetricians, perinatologists, pediatricians, and social health workers. Everyone were involved, and from both developing and developed countries, they decided what to do, and they have come with ICD perinatal mortality classification. So this ICD perinatal mortality classification, this includes both
You're not audible. Kirti? Hello? Kirti? You're not audible?
No, her signal has gone probably.
सिस्टम में हैंग है
I think what she was explaining is very important, that the classification is quite,
so
yeah.
Am I visible?
Yeah.
So it's now we can.
You were not audible for some time.
Okay.
Can
just-
we see the previous
Madam,
slide?
Namaskar.
Uh-huh.
Namaskar, Director Family Welfare. Connected. It is also
Yeah.
audible.
So thank you, sir, for joining.
Sir.
Shall we complete Kirti's presentation?
Yes.
দুই তিনটা
Sure.
স্লাইড পছকু যাଆନ୍ତୁ ম্যাডাম দুই তিনটা স্লাইড পছকু যাଆନ୍ତୁ
এটা দেখিଛୁ
यहाँ पर
এটা ବି ଦେଖିଛୁ
Yes, we have seen this. Yes,
Eight is
এটা
done.
ଦେଖିଛୁ
from here.
Yes. So WHO application of ICD. This ICD-10 death during perinatal period. It is developed by WHO working group. This WHO working group was formed by taking obstetricians, perinatologists, social health workers, as well as pediatricians from both developed and developing countries. And they've made the plan and decided what to do. And this was released in August 2016 for this classification, that is ICD-PM. PM means ICD perinatal mortality classification. Here they have included both stillbirth as well as early neonatal death. And we are not new to it, because this ICD-MM, that is ICD maternal mortality, is already we are doing. So it is not very new, but here they have included early neonatal death along with stillbirth. So it is very simple. It doesn't it is not complicated. It is very simple. It is an easy way of classification, captures the chain of events. That means, suppose there is a complication pre-eclampsia, it gave her to intranatal hypoxia and all these things. So it captures the chain of events, this classification, and includes early neonatal death, because early neonatal death and stillbirth, they are almost the cause is, etiology is continuous. Etiology is almost same in most cases. And it is a reflection of this early neonatal death is a reflection of intrapartum care and maternal diseases. So it is also included. So it has two attractive points. One is timing of death, whether it is antepartum, intrapartum, or neonatal, and multi-layer, different causes, different diseases they are tackled. And always this perinatal mortality, this is linked to maternal condition, because fetus is a parasite on mother, and any maternal condition, it will affect the health of the fetus. And many of the stillbirth are due to maternal disease and maternal condition. So in classification of perinatal death, that is also stillbirth and early neonatal death, maternal condition has to be entered. So it is entered in this classification. So to do that, we need the birth certificate, death certificate. According to WHO death certificate for all death regardless of range, you can see different columns here, different columns, and the last one different rows, and last row is main disease or condition of the fetus or infant which gave rise to complications the above ones and the immediate cause of death. Along with, in this form, another condition is there, that is maternal condition, main maternal disease, where when the fetus dies. These two things are recorded in the death certificate, and these two can be taken, and most of the classification, they can be classified. So for this antepartum death, there are all the causes are grouped into 6 groups: A1, A2, A3, A4, A5, and A6. A1 is congenital malformations, A2 infections, antepartum hypoxia, and other specified antepartum disorders, and A5 is related to fetal growth, and A6 antepartum death of unspecified cause. And all the ICD codes are given to all groups. Similarly, the intrapartum deaths, here also the causes are grouped into 7 groups: I1, I2, I3, I4, I5, I6, I7. I1 is congenital malformation, deformation, chromosomal anomalies. I2 is birth trauma. I3 is acute intrapartum event. I4 is infection. I5 is other specified intrapartum disorders. And I6 is disorders related to fetal growth. And I7 is intrapartum death of unspecified cause. And all the ICD codes are there. ICD-10 codes are there for all the groups. And maternal conditions, we have discussed here. All the deaths, we have to specify the maternal condition. Again, there are 5 groups. Complications, M1 is complications of placenta, cord, and membranes. M2 is maternal complications of pregnancy. M3 is other complications of labor and delivery. M4 is maternal medical and surgical conditions. Even if there is no maternal disease, we have to stamp it as M5. There is no maternal disease, relevant maternal disease. And all ICD codes are there. Neonatal death, again, there are 11 groups, and ICD codes are given for that. Whenever you are tabulating or you are reporting death, you have to give this ICD-PM tabulation code. Here you can see both the groups are taken together. Suppose there is an antenatal death, antepartum death. Here, suppose it is due to congenital malformation. You can report it in this row, but you have to see the maternal condition. Even if there is no other maternal condition, you have to report it in this column. So similarly, when you see, you can notice that how many cases of congenital malformation occurs in maternal medical or surgical conditions like diabetes, or without any maternal disease. If you want, you can get all the data and you can compare. Similarly, intrapartum death, all the causes, you have to see the maternal conditions above that, like this, and you can tabulate, and at last you can get the result. And also perinatal causes like early neonatal death, you can do this way. So this is simple as like that. And applying ICD-PM will decrease the errors in coding and improve attribution of causes and usability and comparability of perinatal mortality statistics. Because tabulation is, if you do it in a proper way, at a glance you can tell what is the most important cause, what is the least important cause, like that. So these are certain journals who have studies where they have shown that how this ICD-PM classification has helped. Here, there is a study, the Indian study, and they have seen that they compared it with another system, and they have seen that ICD-PM classification stillbirth were categorized more clearly in different groups, and feto-maternal conditions were linked together along with both intrapartum and antepartum stillbirth, which can help to see the priorities and future planning for prevention. The proportion of unexplained stillbirth has been reduced significantly compared to Kodak system. Here they have compared it with Kodak system. You can see this unexplained stillbirth, we have to eliminate as far as possible. Another study, that is Chinese study, they have also primary outcome as the reduction in unknown causes of stillbirth and neonatal death after applying the ICD-PM coding system, and secondary outcome was the percentage agreement with expert in applying ICD-PM codes. So definitely it is till now it is a proved method. And how to classify, just one example, because as it seems very difficult, but once you do it, it is very simple. Suppose a 36-year-old primee presented at 35 weeks complaining of a headache, decreased fetal movement, clinical and biochemical tests reveal maternal proteinuric hypertension. Male child vaginally after the induction of labor. So, what type of death is this? This is antepartum death, because the baby died and she delivered a macerated male child. And cause of death is intrauterine hypoxia, and maternal condition here is preeclampsia. So let us show how we'll classify. Main disease condition in fetus, that is intrauterine hypoxia, ICD-10 code is P20.2, and other disease or condition in the fetus is prematurity, that is 36 weeks. So the code is P07.3.3, and main maternal disease here is preeclampsia, that is P00.0. So the final ICD-PM group here, antepartum and intrauterine hypoxia. So it is A3, and maternal medical disease. So it is M4. So A3 ICD-PM group is A3M4. So it is as simple as that. So to conclude, stillbirth is a silent epidemic significantly which impacts and burdens families. WHO definition changed for better comparison of data because we have shifted it to 28 weeks, the lower limit. WHO application of ICD-10 for perinatal death is called ICD-PM or perinatal mortality, where they have included early neonatal death. It links causes of perinatal death using ICD-10 codes. Mention the codes separated by timing of death and maternal condition. That is just like A3 and M4. it links the stillbirth to maternal disease. That is very important because during pregnancy, we can treat the mother if you know which conditions will give rise to more cases of stillbirth. It helps program officers and public health workers to drive interventions. Thank you.
Thank you very much, Kirti madam. Now we have our Director Family Welfare who couldn't join. We want to have his important message and words. And at the outset, please stop sharing. Kirti madam, please stop sharing. Dear sir, welcome, sir. Where is sir?
Tara joined, I think.
He joined and then he's left over.
No.
Anyway, hello. Hello, sir. He's lost contact. Lucy madam, please give him a ring. Lucy madam. Hello, Lucy madam, please give the DFW a ring.
Yes, madam. I'm giving.
We're all waiting for him.
Sarah joined, but there is frequently he is disconnected. So he is telling you just continue. I will join the meantime.
So should we go on to the next topic or should we wait for him?
No, we'll go to next topic.
I think next is Dr. Abhipsa Rath. She is one of our best outputs from SCB. As a postgraduate, she did her senior residentship at Bhubaneswar AIMS. So she
as well as assistant professor from this college, SCB.
And then she came as an assistant professor. Then she is now a bona fide assistant professor in the state service. And she's at Jagannath Medical College, Puri, and very well with all the training that she has got from SCB and from AIMS. And she had come to this perinatology conclave, so I said she should be given the privilege of participating in this webinar because she was there from day one throughout the webinar conclave, perinatology conclave conducted at JIPMER. She was the only one from Odisha other than me who had attended. So now I request Abhipsa, please share your slides, and you will be speaking to us on major maternal risk factors for stillbirth. She wanted 10 minutes, so that's why I gave her 10 minutes. Abhipsa, please share your screen.
Thank you, ma'am. I'm sharing. Namaskar to all my teachers and mentors. Stillbirth is the end result of various maternal, fetal, placental, and other risk factors and other causes. But for now, I'll be talking about the maternal risk factors only. There are various maternal risk factors which are involved in causing stillbirths, like socio-demographic, age, race, ethnicity, and socioeconomic status. There are various obstetric conditions and medical conditions, but I'll be discussing the major maternal risk factors. Maternal age. Rates of stillbirth are higher at either ends of the spectrum, with less than 15-year-olds having rates of around 7 to 13 per 1,000 live births, and more than 35-year-olds having rates of around 11 to 21 per 1,000 live births. The lowest risk age group is 25 to 29 years, and rates in less than 15-year-olds are 3 times that of this age group. As more and more women are choosing to get married later in their lives and have pregnancies at later ages, older maternal age is upcoming as an independent risk factor after controlling for confounders like hypertension and diabetes. Similarly, parity, like nullipara and parity more than 3, have reported risks of higher stillbirths. Hypertensive disorders. As we all know, pregnancy-induced hypertension are becoming a major challenge that obstetricians are facing all over India and especially in Odisha. They have major implications in increasing the maternal morbidity mortality as well as resulting in poor fetal outcomes. It has been reported that chronic hypertension results in 6 to 25 stillbirths per 1,000 live births. Similarly, non-severe and severe preeclampsia report rates of 9 to 51 and 12 to 29. South Asia contributes a major chunk of stillbirths to the global rates, around more than 1/3, and the primary cause in these cases, around in 36%, is hypertensive disorders, according to a prospective cohort study conducted in hospitals across India and Pakistan. The major mechanism behind these fetal demises is defective endovascular trophoblastic invasion, resulting in placental insufficiency and abruption. When pregestational diabetes complicates these hypertensive disorders, the risk becomes even higher. The two most common comorbid conditions in pregnancy are hypertension, and the second one is diabetes mellitus. Population-based studies report risks 3 to 4 times higher in pregnant women who have pregestational or gestational diabetes. When treated with diet, the rates are around 6 to 10 per 1,000 live births, and when treated with insulin, they are around 6 to 30 per 1,000 live births. Unexplained stillbirth is a phenomenon characteristic to overt diabetes, which has been attributed to poor glycemic control. The fetuses in these conditions are usually large for gestational age and die later in the 3rd trimester before labor. A fetus of a mother with pregestational or gestational diabetes mellitus is at risk of stillbirth primarily because of two major mechanisms. The first one being fetal hyperglycemia and hyperinsulinemia, which result in increased oxygen consumption and increased hypoxemia, finally resulting in increased acidosis. Lower mean umbilical venous pH has been observed in these fetuses. The second most common important mechanism is the maternal hyperglycemia and vasculopathy, which result in reduced uteroplacental perfusion. And when these women also have hypertension, the risk of having a stillbirth becomes 7-fold higher. Coming to acquired and inherited thrombophilias. APS, or antiphospholipid antibody syndrome, is an acquired thrombophilia which has been significantly associated with stillbirths. It has a set of predefined laboratory and clinical findings, which will be discussed subsequently in the upcoming discussions. More than one unexplained fetal death at more than 10 weeks of gestation with normal fetal anatomy in the presence of defined laboratory findings is one of the defining morbidities of this condition. On the other hand, inherited thrombophilias like antithrombin, protein C, and protein S deficiency, these have not been also found to be associated with any stillbirths, hence routine testing is not recommended. As lifestyle changes are occurring, so are the rates of subfertility rising, hence the increase in artificial reproductive techniques in achieving viable pregnancies. These women are at 2 to 3-fold increased risk of having a stillbirth, and these rates are around 12 per 1,000 live births after controlling for their parity and multifetal gestation. The main cause behind these fetal demises could be attributed to the procedure itself or to the basic cause of subfertility, but is still not clear. A large proportion of term stillbirths are attributed to obesity, and it is one of the highest ranking modifiable risk factors, resulting in 13.6-fold high stillbirth rates compared to normal weight gravitas. Obesity is defined as a pre-pregnancy BMI of 30 kg per meter square. Risk increases with gestational age, and it is also an independent risk factor after controlling for smoking, GDM, and preeclampsia. IHCP, intrahepatic cholestasis of pregnancy, which presents in the later half of pregnancy as pruritus with rash and jaundice, is another major cause of sudden stillbirths. Higher bile acid levels have been associated with higher rates of stillbirths. Past obstetric history, like a history of previous stillbirth, especially in the index pregnancy, prior preterm delivery, and prior growth-restricted fetuses, have shown to be associated with stillbirths of around 10 to 30%. Illicit drug use, though not reported appropriately and is difficult to estimate, still smoking tobacco, cocaine, methamphetamine have been associated with higher rates of abruption and stillbirths. Smoking increases the odds of having a stillbirth by 47 to 52%, which is dose dependent and confers higher risk at the first trimester. In non-smoking women, exposure to secondhand smoking has also been associated with a higher rate of stillbirth than women who are not exposed to any kind of smoking. There are various other factors like late-term and post-term pregnancies, hypo or hyperthyroidism, SLE, chronic kidney disease, sleep-disordered breathing. As we can see, a major chunk of stillbirths remain unexplained still. But there are a large number of modifiable risk factors like obesity, preeclampsia, poor glycemic control, and fetal growth restriction. As we will see in the upcoming discussions, all these risk factors are modifiable, are preventable, have specific preventive measures and monitoring protocols in place. And we just have to follow these to achieve better fetal outcomes. Thank you.
Thank you very much, Bipsa, for a very brief but very elucidating data on the aspect that you have chosen. And next we go on to Dr. Chinmay Rath's presentation on fetal surveillance to predict and prevent stillbirths. Dr. Chinmay Rath, as you all know, hello, am I audible? Yeah. She is the director of Resolution Fetal Medicine Center and Research Institute. She's senior consultant of fetal medicine, Yashoda Hospital, Hyderabad, and she's chairperson of Perinatology Committee of FOGSI for 2021 to 24. And we had a wonderful conclave at Jipmer, Pondicherry, and which she held it at Pondicherry because of the mystic atmosphere that prevails at Pondicherry, and Jipmer also responded in a wonderful way with Lata Chaturvedula, the professor head of OBGYN over there, and all the medical colleges in Pondicherry that participated and made a wonderful learning forum and workshops. So, Chinmay, as you know, we had wanted her to involve with the ultrasound training, but we didn't have it directly, although she participated in the on-site mentors hands-on. So now, Chinmay, you will talk to us on the very important aspect of what all obstetricians can do with the ultrasound machine and their clinical expertise to predict and prevent stillbirths.
Thank you. Thank you so much, Shama ma'am. And it's a real honor to be here on this platform. And also very, very inspiring that seniors like Shama ma'am take the trouble to travel long distances and learn new things so that, they can come back and create a platform for teaching. So as we have already heard from Dr. Kritireka's presentation and Dr. Abipsa's introduction, that the stillbirth is a well-defined entity in clinical practice, and there are many causes, some of which are modifiable, some of which are not. But what we must remember that because of our large population, because of the birth rate at which we are progressing, we are amongst the first 6 countries which are accounting for almost half of the stillbirths that are occurring. So India, Pakistan, Nigeria, Congo, Ethiopia, and Bangladesh. If you see these countries, together they are contributing to almost half of the world's burden of stillbirths. And the stillbirth rate is still an important indicator of quality of care provided during pregnancy and childbirth. Now, it doesn't look fair because India is progressing very well on many counts. But again, because of the population, we still have a high number, and we are actually tamed with the countries which, in terms of economy, in terms of education, in terms of other things, are really not comparable to us. So we need to now reduce the stillbirth burden. And this is still very significant when we look at the estimates. We have still not touched the average number. And sadly, Orissa is still in one of those high mortality zones, because if you see the last survey, they have put Orissa, Madhya Pradesh, Chhattisgarh, and Rajasthan as one of those belts which is still higher than the national average. And therefore, we need to really focus our efforts. And I congratulate Shyama ma'am on thinking of this concept of bringing together the experts to think of prediction and prevention. And again, we've already heard about the cause and classification of these stillbirths. So when we talk of these maternal, fetal, or placental problems, my topic is to look at fetal surveillance to predict or prevent stillbirth. But if you see all these causes, maternal, fetal, and placental, they are all interrelated, and final common pathway is afflicting the fetus and causing a stillbirth of the fetus. So this classification, madam just told us. And she also said it's a very fashionable term to say unexplained, but unexplained is only waiting to find an answer. So this recode classification, which is relevant conditions of death, has actually helped in reducing the number of unexplained, because we have been now able to give them a category. And if you see these categories, I'm not going into the detail, but if you see these categories, it's very much, takes into consideration all these factors. And why I'm talking about this in my topic is because all of this, each one of this, the final common pathway is fetal affliction, and fetal affliction therefore needs to be monitored. And that is my topic, fetal surveillance for predicting and preventing stillbirths. So antepartum and intrapartum, what can we do? So antepartum, one of the most important causes of stillbirths after we've ruled out anomalies and aneuploidies, is fetal growth restriction. And this can affect 3 to 9% of all pregnancies, and up to 30% of preventable stillbirths fall in the category of what is called fetal growth restriction. So we know that the most important thing here is dating the pregnancy. Hence, early pregnancy care becomes an important point where the obstetrician can contribute in preventing stillbirth. So what is happening at the end of pregnancy can actually be predicted and prevented at the beginning of pregnancy. So when this ultrasound training program, which Shama ma'am was talking about, when that was started, one of the important things taught to all the trainers were that you look at the fetus in the 6 to 8 weeks period, do a crown rump length, document the date on which you took the crown rump length, so that it helps in dating the pregnancy, because biometry will vary in the third trimester, but in first trimester, it is very much within some minimally variable range, and therefore that can be useful in dating the pregnancy. Suppose a woman has symmetrical IUGR, you will be having difficulty dating it in late pregnancy. So early pregnancy dating, serial biometry, and the use of Dopplers are the most important things in preventing stillbirth in a case of fetal growth restriction. We know that fetal growth restriction is a condition where in utero growth is restricted for various reasons. But what is the problem here? The problem is the fetus is unable to grow. So what is the treatment? The treatment is deliver the baby, because in utero fetal growth restriction, ex utero it will catch up. But can you deliver at all gestations? You can't. You can only deliver at a gestational age when viability is assured and your neonatal intensive care unit is happy to take the baby. So both these factors are limitations to delivery. So when the baby is inside, you have to balance the risk of prematurity versus the risk of stillbirth. And how can we do that? We can watch the uterine flow, blood flows in the feto-placental unit, and we can improve the intrauterine environment if possible. So in the feto-placental unit, we have this circulation that goes from the placenta in the form of oxygenated blood that comes through the umbilical vein and by the ductus venosus enters the fetal heart. Then the fetal heart has pure blood that is coming from placenta, which it distributes to the rest of the body by sending it through the aorta. And then it gets, at some point, it starts collecting the deoxygenated blood, which comes from the right side by the ductus arteriosus. And then it goes on and becomes the umbilical artery, which ultimately goes back to the placenta for further clearance of the deoxygenated blood. So this circulation is very important because in this, there are 3 landmark areas. One is the umbilical artery, which is the deoxygenated blood that is flowing from the fetus to the placenta, and one is the ductus venosus, which is the oxygenated blood coming into the baby from the placenta. Then you have the middle cerebral artery, which is a sign of central redistribution, because nature has decided that when blood comes to the heart, the most oxygenated part goes to the brain. And then the ductus arteriosus meets the arch of the aorta, and then you have a little bit of a mixed kind of blood there. So this oxygenated blood, which comes to the brain, is at a very, very high oxygen level. And when that level starts decreasing, there is a level of hypoxia there, and the diastolic blood increases because there is cerebral vasodilatation. The blood which flows in the umbilical arteries is a sign of placental resistance. So as placental resistance increases, the resistance in the umbilical artery increases. The ductus venosus is a sign of incoming oxygenated blood. So when that gets affected, then you are really, really worried, because now this baby is at real risk of stillbirth. So in the umbilical artery, you have a normal flow, you have high resistance flow, you have absent diastolic flow, and then you have reverse diastolic flow. And as you can make out, as the umbilical artery worsens, the risk of acidosis increases. Hypoxia is always there in IUGR, but when acidosis increases, the risk of accumulating bad products in the body increases, the risk of irreversible neurological damage increases, and the risk of stillbirth also increases. And that is where we have to intervene before the acidosis sets in, before the stillbirth sets in. Otherwise, we will not be able to prevent the problem of stillbirth in these conditions. The blood flow in the brain, that is the middle cerebral artery, is a surrogate representation of hypoxia in the brain. So when you have high diastolic flow, you can see here on the left side of the screen, you have low diastolic flow, and the right side of the screen, you have high diastolic flow. High diastolic flow indicates cerebral redistribution, indicates a level of compensation that is already happening, because the blood flow is happening at a stress in the baby. So this is what happens as the level of growth restriction increases, as the severity of growth restriction increases, we correlate that to the severity of the placental insufficiency. And when it is really bad and leads to stillbirth, you see abnormal ductus venosus flows, you see abnormal CTGs in terms of fetal heart rate decelerations. And after that, if you leave the baby in utero, the baby will die. So if these changes are occurring at 37, 36, 34 weeks, you will probably deliver the baby, because the baby is better off outside than inside in such a bad condition. However, if these changes occur at 26 weeks or 24 weeks or 25 weeks, you may not be able to prevent that stillbirth. So predicting stillbirth by Dopplers is not difficult, but preventing stillbirth by Dopplers depends on what is the gestation at which the Doppler is getting abnormal and what is the neonatal intensive care facility that you have. So in some places, like in Hyderabad, at 27, 28 weeks, we are happy to deliver these babies because the neonatology units are good enough to sustain and preserve these babies. But and in the peripheries, I don't think 27, 28 is a very welcome gestational age. So there you may have to balance the risk of delivering so early and having an infant death as compared to stillbirth, because in any case, the outcome is going to be poor. So there are many things where prediction is easy, but prevention is not always easy, and one has to look at the practical circumstances of that place. So when you look at Dopplers, the role of Dopplers is to predict the level of placental insufficiency, so that whether it is at the state of hypoxia or it is at the state of acidosis or it is at the state of impending death, you can predict by a Doppler. So once you can predict, you can time the delivery. This was the earlier GRIT trial, growth restriction and intervention trial, which gave us some guidelines about how to deliver. But practically after the Barcelona protocol has come in, we have all started using this stage-based management. Not very different from what the GRIT trial says, but this is easily depicted. You go stage-wise. If you have really bad situation at 26 weeks, and you have a good NICU, think of delivery. Otherwise, pull till 30, pull till 34, pull till 37. So at every stage, this chart is self-explanatory. I'm sure most of the fetal medicine people in this group have already seen these chart. Others can take a picture of this chart. And it is very, very self-explanatory that based on the Doppler abnormalities that I explained earlier, you try and deliver a baby to prevent stillbirth at different stages based on the risks that you are taking. But here it is also important to understand that there are two types of IUGR. Now, IUGR is also not so simple. You have early IUGR, which sets in before 32 weeks, and late, which sets in after 32 weeks. But the important thing is, while in early IUGR, it is very straightforward. You look at this IUGR, there is already a growth restriction that has set in almost 24 weeks. And you know that the cause can be very, very sinister. And when you look at the scans, you may have a huge placenta like that. You may have very bad Dopplers. And here, prediction of stillbirth is not at all difficult. But prevention is impractical because it's only 22 weeks. And by 26 weeks, when you see there has been a stillbirth. Now, here it's an early stillbirth. If you remember the classification that Kirti Rekha madam said, we are talking only about stillbirths after 28 weeks. So this will be classified in the international classification just for a cause allocation, but we know that we could not prevent it. However, when you have a history like this, where you have a previous very severe IUGR and infant death, and here you see the prediction starts with the first trimester biochemistry, a PAP-A of 0.1 mom. And you see that there is a risk of growth restriction in this particular pregnancy. But with good serial monitoring, protein intake for the mother, high fluid intake, and a lot of follow up, you managed to pull the pregnancy till a very nice viable gestational age. And although the baby is small, it could go till full term, and that is the placenta just cooperated with us. This is another case where you have a 45-year-old mother with a known case of diabetes and hypertension, both of which, Abhipsha told us, both of which are risk factors for growth restriction and stillbirths. And in addition to that, there is a low PAP-A, 0.27 mom, increased resistance in umbilical artery, and absent and reverse diastolic flow in the umbilical artery at 25 weeks. So these are cases where whatever you do, you can predict the stillbirth, but you may not be able to prevent it in a justified manner. So in some other conditions, you can just go with serial monitoring and you can deliver small babies, 1.8 kg, 36 weeks. We delivered for reduced fetal movement. So we will come across to other clinical parameters, because when the baby is very small, Dopplers may be okay. But once the clinical signs of reduced fetal movements come up, we then again intervene to prevent an unexpected stillbirth at that point. So here comes the role of late onset growth restriction, where your Doppler abnormalities may not be very bad, but suddenly there might be a stillbirth. Why? Because here the reason that the placenta doesn't function very well is there are very little villi in this particular pregnancy. And when you see there is very little maturation of the villi in this pregnancy. And if you see the trend of fetal growth, the fetus which was growing at 50th centile has suddenly come down to like 10 centile or 15 centile. And there has been a huge transition of the growth centiles in the third trimester. So in early onset growth restriction, there are very few villi. In late onset growth restriction, you have a good number of villi. I'm requesting some of you to please be mute. In late
Please,
onset
everybody keep muted. Host, please mute everybody, excepting the speaker.
In late onset growth restriction, you have a lot of villi, but they are not mature. And therefore, the Doppler changes don't happen that much, but the effect of hypoxia happens. And that is the reason of increased morbidity and mortality. So I'm giving a very crude example because, when you talk about Dopplers and everything, everyone gets confused. Early onset IUGR is like this student A. Student A is a poor student. If you see the grades of student A, it is always C, D, something. The student is just, managing to pass all the exams. That is early onset IUGR. Very poor villi, very badly formed placenta. Somehow that baby is growing. Here you are expecting stillbirth. So in this student A, you are expecting the baby might fail. But like in the second case, it carried on till 38 weeks, had a 1.8 kg baby, but delivered. So here the student passed with a grade C. Student B is a good student. You see, grades A, B, everything till the last semester. But something happens in the end, gets distracted or, buys a new iPhone or I don't know, whatever happens. Suddenly, you see there is a fall in the grades and then fails the final exam because it has got a grade F. And you fail the final exam, you fail the class. So a late onset IUGR is like this good student who suddenly has a, bad result and you don't anticipate it. In the first case, it is an anticipated problem, even if it is there. And sometimes you may actually plan a preterm delivery and salvage the baby. But in the second case, it is a completely unanticipated IUD. So many of you clinicians might have had babies of 2.2 kg, 2.4 kg at 9 months who've had IUD, and you think, what is wrong? I did everything correct. How did that baby have IUD? Dopplers were not bad last week, because we were not looking at the Dopplers that critically, and we did not realize that there has been a fall in centiles of the growth in the third trimester. And that is what is late onset IUGR. And that, you must remember, looking at one Doppler might fool you. So in late onset IUGR, look at two Dopplers, that is the umbilical artery and the middle cerebral artery, and take a compound measurement called the cerebroplacental ratio to see whether things are altering there. Mind you, alone CPR is not an indication for delivery, but in the settings of IUGR, in the settings of late onset IUGR, in term delivery, you can use a CPR to time your decision for delivery. The other thing that we use in the antenatal period is fetal heart rate monitoring, not just with the Doppler, because Doppler can give you a headway of 2 weeks. If the if Doppler is abnormal, maybe 2-3 days also you have. But when do you decide to deliver? The decision for delivery is based on CTG, and CTG is nothing but cardiotocography, where you look at uterine action and you look at fetal heart rate pattern. So Dr. C. Bravado, all of us have read about it. Define the risk, contraction, baseline, variability, acceleration, deceleration, and overall interpretation. So these are the 4 important things: baseline, rate, variability, accelerations, and decelerations. So whenever we have decelerations or loss of variability, those are sinister signs, and especially late decelerations are signs of uteroplacental insufficiency. So whenever we see decelerations or prolonged large decelerations, we must deliver the baby within 30 minutes, because that is the decision for delivery trigger is the CTG. Doppler is your indication that may need delivery, but the final decision for delivery will depend on a CTG. And these decelerations are really, really important. So it's good for all of us to learn our CTGs. The NICE has given very good guidelines. We have the FIGO, which gives good guidelines. So there are a lot of guidelines where we can use the CTG. Coming to a very, very common thing, you see, the states that we were targeting: Odisha, Madhya Pradesh, Chhattisgarh, and Rajasthan. I don't know how much Doppler and CTG we can teach everybody in every place, but we can always teach women to do fetal movement count. It might sound like a very low budget, out of date intervention, but let me tell you, this also has a role. So amniotic fluid measurement is almost corresponding to a good fetal movement sometimes. But when you measure the amniotic fluid, a single deepest pool more than 2 centimeters is enough. So whether you do a 4-quadrant measurement or a single deepest pool, it should be enough. Usually when the Leica is less, people have reduced fetal movements. But if somebody has marginal Leica and good fetal movements, we can follow up with the fetal movements. So NST, amniotic fluid volume, and the ultrasound assessment of fetal breathing movements, fetal body movements, and the reflex tone and flexion extension movements can be what is called the biophysical profile. And the biophysical profile is also a very good predictor of the risk of stillbirth. So we have 2 types of biophysical profile: one where we do the complete extended version of it, or we do the modified biophysical profile using only the amniotic fluid volume and the NST. The complete extended version is something not very difficult to do, but when you do ultrasound, you can see these kind of breathing movements. You can see changes in the thoracic contour when the baby breathes, or you can see the diaphragm moving up and down. You can also see movements of the limbs. The things will be, hands will be opening and then closing, the trunk will be shifting a little bit. So when you see at least 3 or 4 movements within the period of your examination, then you know that the biophysical profile is okay. If you don't see those movements, you extend your period of examination to at least 30 minutes and try and notice all this. I agree that it is very difficult to keep on looking for 30 minutes, and hence in those conditions a modified biophysical profile may be useful. But my point to bring out these slides is that when you are doing a regular growth scan, you don't have to finish the scan and then start looking for the movement. So when you're doing the scan, you're anyway seeing these movements. So if you have already noted that the baby is breathing and these activities are happening, then you know that the biophysical profile is good for this particular baby, and this baby has a low risk of stillbirth. So there is a very low false negative for the biophysical profile, although there is a high false positive. So taking a delivery decision only on biophysical profile may lead to excessive intervention, and that we need to be careful of. So feeling fetal movements is not a wrong thing to do. It is a good idea, and it also helps keep the mother included in the pregnancy care plan. And we have a lot of evidence to say that there is a role, it's a warning sign of impending intrauterine fetal death. 55% of women who've had stillbirths have perceived reduced fetal movements. So what is important in reduced fetal movements is to ask a detailed history. Since when have you felt it? How many maternal red flags are there? What has been the antenatal progress till then? Is there any emotional factor which is causing for reduced perception now? And these are all the risk factors for reduced fetal movements. But at the same time, we can teach every woman how to do fetal movement counting. And there is evidence to do that. It may not be grade A evidence. We cannot have randomized controlled trials on stillbirths, but we can definitely have case studies, case series, and a lot of anecdotal reporting, which will help us form a reasonable practice. So you teach a woman doing kick chart like this. So, after breakfast, after lunch, after dinner, she does not have to be educated. She does not have to be literate. She only has to draw lines on that chart after breakfast, after dinner, after lunch, and after dinner. And that keeps her involved in the care of pregnancy, mind you. Because if she is doing it every day, she will come back at the time she feels the reduced fetal movements. And after reduced fetal movements, you always have time. Then you can subject her to a Doppler. Then you can subject her to a CTG and prevent a stillbirth. So when a woman noticing sudden change in fetal activities or in whom risk factors for stillbirths are identified should report to the maternity unit for further investigation. And this definitely can be done. So there is very little evidence for fetal movement monitoring, some of you will say, but do we need evidence for everything? And this is a paper. This is not just me saying, this is a paper in the American Journal of, I think, Orthopedics, which says, do we need evidence for everything? Because some things are very, very self-evident. You say common things, absence makes the heart grow fonder, out of sight, out of mind. Do we have evidence for all these things? Look before you leap. Do you have evidence for all these things? So sometimes even wisdom works. And therefore, for these obvious things, doing a fetal kick count chart may not be a bad idea in states which are poorly allocated in the remote areas. And that will keep the woman motivated about her pregnancy care and lead her to the obstetric unit when she perceives a problem. And these are a number of studies that have been done on reduced fetal movements, and they have shown some evidence that it helps. Now, whenever you see reduced fetal movement, should you deliver or should you wait? So when you want to prevent stillbirth or birth asphyxia, you should have some concrete reason to deliver. Just because a woman has had reduced fetal movements, you need not take her for delivery. You should then take her for a CTG, then take her for a Doppler, and then make a decision for delivery based on that. Suppose you could not prevent the stillbirth. Suppose it's a very difficult decision. You sent her home last night, but she came back with a stillbirth. Then there is a very, very clear-cut area of how to investigate. I'm sure there's a session coming beyond this, how to investigate, because these investigations will help us know whether it was the reduced fetal movement which was the cause of the stillbirth, or there were other factors in the background, and are we missing out what exactly was the cause in the leading to the stillbirth. So with the intention to prevent fetal compromise or stillbirth, a combination of methods can be used for fetal surveillance, and no one of them has been proved to be extraordinarily good. All of them in combination and with a strong clinical suspicion only we can address the issue of preventing stillbirths. In cases where the stillbirth has happened, there is a whole list of investigations that have to be done, because we must not have a situation that we land up in the same condition again. Some conditions do not work. These are these treatments which do not work in cases of growth restriction or reduced fetal movements or reduced AFI. These do not work. But sometimes it is useful to do more, improve maternal nutrition, bed rest, hydration, fetal kick count, weekly ANC checkups, because this helps in improving the overall clinical outcome. At least the woman will feel reassured that something they are trying. We cannot do everything, but we cannot say I can't do anything, because that will make her feel very, very sad. So this is like, preventing bad outcomes in Kashmir. Instead of putting surveillance, the government increased the economic activities there and things got better. So sometimes you want to just improve the overall outcome, and your problem will go into the background, because the patient will get motivated. She will eat better. She will take care of her movements better. She will report faster to the maternal unit whenever there is a problem. So when preventing stillbirth, you start from pre-pregnancy BMI, food fads, adequate supplementation, first trimester screening, serial follow-up. Because stillbirth itself is the biggest risk factor for a next stillbirth. So recurrence of stillbirth is, one stillbirth is unforgivable. But if you have a recurrent stillbirth, then, that's a really, really a very shameful thing for the maternal, the medical medical fraternity. And therefore, we have to prevent the primary stillbirth, and at least if we can't prevent that, identify the risk factors and prevent recurrence. So in subsequent pregnancies, we should always have a detailed medical and obstetric history, evaluation for the previous stillbirth, cessation of smoking, weight loss in obese women, genetic counseling if there are genetic conditions, diabetic screening if that is in the background, thrombophilia screening and testing if that is in the background, and of course, support and reassurance. In the antenatal care, you do your dating scan. Dating scan is the best scan to prevent the risks of FGR. And if we do that, at least 20% reduction of bad outcomes of FGR. First trimester screening, uterine artery Dopplers, and if possible, the pregnancy-associated plasma protein A. Sonography to rule out anomalies, sonography to do growths, sonography to do Dopplers. So sonography is really important in preventing stillbirth. And of course, placental localization and other things that can, indirectly cause stillbirth in the fetus. Decision for delivery is a very, very complicated decision. And, with this time to induce 39, 40, 41, again, in the perinatology conclave, we had another session by Dr. Palaniappan about when to induce normal babies, when to deliver normal babies, 37, 38, 39. And he gave a very logical approach to that decision, which is again questionable, but at least 37 to 40, we have reasons to, intervene. What are the risk factors? There are risk factors that are modifiable at the family level, at the administrative level, and at the provider level. And in a meeting like this, where we have our administrative officials also with us, I think it's very important that we form a sort of consensus how we are going to modify these risk factors. Awareness of stillbirth. Every woman should know that she is at risk of stillbirth. Patient awareness, provider awareness, and administrator awareness. Everything cannot be prevented. So the government cannot give us certain numbers that, your stillbirth has to be less than this. Well, it has to depend on so many factors. So physicians can make an effort, but public awareness is very important. And this was a wonderful paper where they said exploring first-time mothers' experiences and knowledge about behavioral risk factors for stillbirth. So, there is a general lack of understanding in the link between behavioral factors and the pregnancy outcomes like stillbirth. So the impact of action taken in response to a stillbirth audit shows that if you audit your stillbirths, if you find out the reasons and then go on to make prediction and prevention strategies, you will be in much better ground. So suspect in every case, optimize pre-pregnancy health, appropriate screening tests, and conscious serial follow-up. All those in green, we have already talked in a lot of detail. So we always have to balance the odds with the motto of first do no harm. And before I finish, allow me to tell you just one little story. One day, one old man was walking along the beach and he saw that one little boy was picking up something and throwing it back into the ocean. He asked them, "What were you doing?" He said, "I'm throwing these starfish back into the ocean because if I don't throw them, they will all die." The old man said, "There are thousands of starfish there, child. What are you doing is so silly. You'll never be able to prevent them all. So many of them will die. So why are you throwing just one?" Because the child picked up that one starfish, threw it back into the ocean, and he said, "At least for that one, I made a difference. At least for that one starfish, I prevented deaths." So that is the whole aim with which we go to prevent stillbirths, that each baby counts, each one of us can make a difference. So if we teach the smallest of things, counting of the fetal movements, coming for serial scans, getting the first scan done and getting the dating corrected, I think we can make a difference. With that hope, thank you very much for this opportunity.
Wonderful, Chinmay, for both aspects of your presentation, especially the last one, the motivating one, and hopefully touches the heart of all the specialists, all the healthcare providers who are watching this, and those who have not been able to come. This is being recorded, and definitely we will take this to you, to every obstetrician and gynecologist and every doctor in the delivery points and every midwife at the delivery point. Thank you very, very much, Chinmay. I can't thank you enough.
Thank you.
And so we'll be calling you more and more in our efforts to prevent maternal mortality and perinatal mortality. Hopefully DFW has joined, or shall we go on?
Ma'am, any questions? We can ask any questions or comments, not questions.
Yes,
rather.
Lata.
I'm Lata here.
Welcome.
I've joined.
This is
Hello, Lata ma'am.
Lata Vedula,
Yeah.
and we are very lucky to have her
Ayyo,
here.
ma'am, please, no.
Gynecologist of Odisha who have not been able to see you because they didn't go to Jipmer. That's why I brought you here to see them, and
Thank
they
you,
will
ma'am.
see you and learn from you and be inspired by you. Thank you, Lata. Yes, questions we will keep definitely,
Okay.
but let's go through the
Sure, sure.
presentations. So keep your questions at least in the chat box. You can give your questions, and I would request all the presenters to be there till the end to be able to answer questions. So please give your questions in the chat box, and of course directly you can be asking questions when we can unmute you, and that will be, let's finish the presentations first. Okay, now we go on to the next speaker, who is none other than Professor Shubhra Ghosh. Once the tragedy is there, and we look at the poor patient, poor pregnant woman with her lap empty, and perhaps not for the first time, for many times, for several times, because she's faced some callous healthcare providers. What to do? So, Subhra, repeated stillbirths have occurred, or even one stillbirth has occurred, need not be repeated. How to counsel this woman and how to investigate that this particular tragedy does not recur. Dr. Subhra Ghosh, please share your slides. Dr. Subhra, please share your slides. She was one of our best students, and I was her first obstetrician. When she was appearing for the MBBS, she had her first baby, and sleeping on the, I mean, in her after delivery, she had appeared for her examination, but she was one of the best graduates, and she was a brilliant student also, and a very human being. She is the head of the department of Sri Jagannath Medical College of Puri. So, Subhra, please share your slides. You have an important presentation for all of us to learn from. Share your slides.
Respected Sama Madam and all the dignitaries, good morning everybody. My assigned topic, thank you for the chance given to me. I have been assigned the topic of counseling and investigating in RPL. Though the topic is a bit different from stillbirth, it has many similarities and the psychological impact the woman is no less than a stillbirth. So my topic will be on my slide.
You can see your slides. Make it a slideshow mode. We can see your slides, Subhra. Make it into slideshow mode. Hello? Hello, Subhra.
Just a minute, madam.
Yes, yes. Net wise, you're okay over there?
Madam, just go to slideshow up there. Slideshow.
Slideshow
animation पाखरे slideshow लिखा है
animation पाखरे ऊपर टूल बार पाखरे अछि
हाँ
आउट के ऊपर
ए होम नाली रे लिखा है ता पाखरे देखो तो फोर्थ
हां तापरे होम इंसर्ट डिजाइन सीट जो अछि नेता तळ लाइन
तळ लाइन
हां yes yes
ଏଠି ନାଲିରେ home ଲେଖା ହେଇଛି।
ନାଇଁ ଆଉ ଟିକେ ରାଇଟ କୁ ଆସନ୍ତୁ
Ita.
ସେମ ଲାଇନ ନାଇଁ ନାଇଁ ନାଇଁ
Ita.
जो-
ଏଠି ଉପରେ ଦେଖନ୍ତୁ ମ୍ୟାଡାମ ନାଲିରେ home ଲେଖା ହେଇଛି।
ऊपर राइट ନାଇଁ ନାଇଁ
home ଲେଖା ହେଇଛି ଏଠି ଆପଣ ଟିକେ ତଳକୁ ଆସନ୍ତୁ। ହଁ ସେ home ଲେଖା ହେଇଛି ତା ପାଖରେ insert design
ତା ऊपर
transition
लाइन टा मैडम जोटे कर्सर टा अछि ता ऊपर लाइन टा
insert ପାଖରେ slide show ଲେଖା ହେଇଛି।
ନା ସେଇଟା ନୁହେଁ ସେଇଟା ନୁହେଁ
ହଁ
ହଁ ଇନସର୍ଟ ତା ପାଖରେ ଆନିମେସନ ସେ जो
ଏଇ animation ପାଖରେ ଏଇଟା ଦବାନ୍ତୁ ହଁ ସେଇଟା ଦବାନ୍ତୁ।
हां
ହଁ
देखो ता पाखे स्लाइड शो अछि
ସେଇ slide show ହଁ ଆଜ୍ଞା ସେଇଟା କରନ୍ତୁ।
Ita.
ସେଇଟା
ना
from
ना
beginning
ସେଇଟା
ନାଇଁ ନାଇଁ ଠିକ ଅଛି ସେଇଟା from beginning କରନ୍ତୁ ମ୍ୟାମ୍। ଏଇନା ଆପଣ କରିଥିଲେ ନା ସେଇଟା from beginning କରିଦିଅନ୍ତୁ ତଳେ ଦେଖନ୍ତୁ ତଳ ଲାଇନଟା ହଁ ସେଇଟା ହଁ ଏଇଟା ହଁ
Click karo.
କ୍ଲିକ୍ କରନ୍ତୁ ହଁ
That's right. Good. Now go ahead.
मैडम आपन म्यूट हे गेला
Unmute karo. Supra unmute.
ଶୁଭ୍ରା ମ୍ୟାଡାମ ତଳେ ଦେଖନ୍ତୁ
Unmute.
ମ୍ୟୁଟ୍ ହଁ ହଁ ହେଇଗଲା ହ୍ୟାଲୋ
यस कंटिन्यू मैडम कंटिन्यू
Muted hai ki?
Not able to hear. Yes.
Hello,
Subra,
Subra,
not
we
able
can't
to
hear you. We can't hear you.
I am audible.
Now you are audible.
Yes, go ahead. Go back to your slide. First slide, please. Now start talking.
Ma'am, I am thankful for the topic given to me. The topic assigned to me is the counseling and investigations in a case of recurrent pregnancy loss. It is a bit different from stillbirth, but they have many similarities, and the psychological impact it causes on the woman is no less than a stillbirth. So I will discuss the counseling and investigations in case of RPL here. So, as all of us know, the pregnancy in human being is a very sophisticated thing. It is very much precious. As for one ovum to be fertilized, so many sperms die. And for one embryo to be implanted, behind one implantation of one embryo, many embryos are lost. But once the pregnancy is diagnosed and it is lost, more so repeatedly, it is devastating for the woman and for her family. So that's why this topic is so important. Many pregnancies are lost, but many gametes are lost. Many embryos are lost, but once diagnosed and lost, more so repeatedly, it is devastating. So, as 70% of all fertilized egg and 20% of all clinically recognized pregnancy will not result in live birth. So to define, a diagnosis of RPL is made when there is loss of 2 or more pregnancies. Loss of pregnancy means the spontaneous demise of a pregnancy before the fetus reaches viability, that is taken as 20 weeks by WHO. The period between 20 to 28 weeks is a gray area, which was discussed by my previous speaker. And these losses may or may not be consecutive. 2 or more losses are taken in RPL. So its prevalence is 1%, around 1% if only clinical abortions are taken. But if we include the biochemical pregnancies, the incidence will be 3%. And the evaluation should start after the second loss. but it should be seriously considered if the embryonic heart activity is present before any loss and the karyotyping of POC is normal and the age of the female is more than 35 or there is a history of subfertility, the evaluation should be started seriously. For the psychological impact is for the woman and her family, the feeling of loss and the grief is same as having a stillbirth, but it increases exponentially when there is repeated loss. Before proceeding for the evaluation, some basic facts about the patient should be educated so that she does not hesitate for an evaluation, and she should know some basic facts about the RPL so that she does not become hopeless. So the basic facts we should be informed to the patient that 1% of all couples trying to conceive have this condition, and in the 50% the no cause can be found, and 70% of women having RPL will have a successful live birth subsequently. And while approaching the patient after RPL, giving time for the patient and good listening, respect for the patient, and honesty, shared planning, etc., are the counseling parts. We should be empathetic, kind, and should give time for the patient and treat this woman, this time, this pregnancy with individual. Individually, we should treat the patient. The approach is different for different patient. And after taking a thorough history and examination, the investigations should be planned. Which investigations are to be done in which patients. Not all the investigations cannot be done in all patients. So we have to plan the investigations in the individual, that should be individualized. And while evaluating the patient in the first visit, a thorough history including medical, obstetrical and family history is taken, and information about the lifestyle of both partners are taken. And the history guides us, it tells us the diagnostic investigations in RPL. And the woman's age and the history of that particular pregnancy is a very important thing while formulating the investigations for that patient. So among all the factors which are responsible for the RPL, genetic factor is the most important cause, because the genetic abnormality is present in most of the lost pregnancies. In the most of the sporadic losses, the genetic abnormality is seen in about 70% of sporadic losses and in about 30 to 50% of RPM. So the cytogenetic abnormality, whether it is present or not, we have to do the karyotyping of the abortus. If the patient presents at the time of the abortion, if the patient presents, then the cytogenetic study of the abortus can be taken. But it is not mandatory, because in most of the abortions, there is cytogenetic abnormality in the conceptus, and for the to show the cause to the patient, it is important. And this genetic study can be done by microarray method or by CGH method. It can be done, but if it is present, if the abortion becomes repeated and the cytogenetic abnormality is seen repeatedly, it is not seen in RPLs. It is not seen in most of the cases of RPL. But if it is seen repeatedly, then we can investigate the partners. We can do the genetic study of the partners. The partners may be balanced translocation. The parents may be balanced, have balanced chromosomes. But when they have reciprocal balanced translocations, there is chance that 50% of the offsprings will be 50% of the pregnancies will be normal, provided the other partner is normal. If they have Robertsonian translocation, there is chance of 30 normal gamete production chance is 33%. So after doing the cytogenetic study, they can be advised whether they will wait for they can take a chance and wait for a normal conceptor, or they can take the IVF and PGT, pre-genetic testing. They can take up, because all the conceptors will not be normal, and in the Robertsonian translocation, only there is a 33% chance of having a normal gamete. That's why they can be offered IVF and PGT. And more so, genetic analysis of pregnancy tissue is not routinely recommended, but it could be performed for explanatory purpose, and it can be done by the CMA method, or it can be done by the CGH method. Parental karyotyping is not routinely recommended in couples with RPL, but if there is a strong family history, or in the obstetric history, if the woman has a normal pregnancy along with the RPL, then it can be done, because if there is genetic abnormality, there is chance of having normal pregnancy as well as recurrent pregnancy losses. So it is not strongly recommended, but it is conditional. It can be done, or it may not be done. Then another important cause of recurrent pregnancy loss is the antiphospholipid syndrome. And this antiphospholipid syndrome may be present in 12 to 15% of cases of RPL, and it is diagnosed before planning for the next pregnancy. It can be diagnosed. It is diagnosed if any one of the clinical criteria and any one of the laboratory criteria is present. If there is a history of vascular thrombosis, or more than one unexplained pregnancy loss more than 10 weeks, or more than one premature birth due to eclampsia, preeclampsia, or IGR, or more than 3 unexplained consecutive spontaneous abortions less than 10 weeks. These are the clinical criteria. If any one of the clinical criteria is present, and the laboratory criteria are there, if there is presence of lupus anticoagulant on 2 occasions 12 weeks apart, or high titer of anticardiolipin antibody IgG or IgM in high titer present more than 12 weeks apart, or anti-beta 2 glycoprotein 1 in high titer more than present on 2 occasions 12 weeks apart. These are the laboratory criteria. So these tests can be advised to the woman, and if one clinical criteria and one laboratory criteria is present, the C can be stamped as a case of antiphospholipid syndrome. For women with RPL, we recommend screening for antiphospholipid antibodies like lipase anticoagulant and anticardiolipin antibodies and beta-2 glycoprotein 1. It is strongly recommended to do these investigations. Then there are, besides the antiphospholipid antibody syndrome, there are other immune factors which also cause recurrent pregnancy loss, like antibody to HLA similarity in HLA sharing, presence of cytokine polymorphism, etc. are also responsible for recurrent pregnancy loss, but the tests for those things are not recommended, and they are too costly, and the result also treatment is not available, so they are not recommended to do in a case of RPL. And if there is history of SLE, etc., anti-nuclear antibody testing can be done. And tests for the detection of natural killer cells in peripheral blood and HLA antibody, etc., are not recommended. Then among endocrine disorders are present in 20% cases of RPL. Among them, thyroid disorder is the most important. These disorders may be present in with other other causes also. These endocrine problems can be present. That's why it is present. It is seen in more than in about 20% of cases. When there is thyroid disorder in subclinical hypothyroidism and in euthyroid women with TPO antibodies, there is increased risk of miscarriage. So these patients can, in all the cases of RPL, the thyroid screening with TSH and thyroid peroxidase antibodies is strongly recommended. If they suggest T4, T3 can be done. So in all cases of RPL, we should go for a thyroid testing, and for other endocrine disorders like diabetes, we should go for the diabetes screening, then diabetes screening and thyroid testing, and other endocrine diseases like polycystic ovarian syndrome, hyperprolactinemia, luteal phase defect, etc. Routine testing of these causes are not advised. If the history suggests or any symptom suggests, if there is hyperandrogenism, oligomenorrhea, history of oligomenorrhea, amenorrhea, hyperandrogenism, or there is galactorrhea, etc., and the luteal phase defect in the conditions where there occurs luteal phase defect, in those conditions, those investigations can be advised. In these conditions, luteal phase defect, the test for luteal phase defect can be advised. And in the, as we know, with the aging of the woman, there occurs more of aneuploidy in the conceptus, because there occurs more aneuploidy in the ovum and more aneuploidy in the conceptus. But in those women, in the women where ovarian reserve is low, there is more chance of aneuploidy. But we can, as the age of the woman is a very strong factor for RPL, stillbirth, and infertility. So with the age of the woman, we can do the advice. We can give the advice for how to improve the ovum status. But the routine ovarian reserve testing is not recommended, and also all other tests are not recommended. An anatomical abnormality of the genital tract is also very important. It is responsible for about 12 to 15% of cases of RPL. There may be anatomical abnormality in the uterus or in the cervix, and the abnormality may be congenital or acquired. So they can be diagnosed, and if they are properly addressed, then the success will improve. If these things are properly addressed, the success will improve exponentially. So to diagnose these conditions, we should go for the investigations, and the investigations which are done to diagnose these conditions. Firstly, we should go for an ultrasonography, then 3D TBS, and if required, we can go for a MRI, or if 3D ultrasound is not available, then we can go for SIS, SSG, and hysteroscopy. So hysteroscopy, diagnostic hysteroscopy is the gold standard to evaluate the uterine cavity, and SIS is also good, but it is not recommended to be done in all cases. It is advised. So the recommendation is all women with RPL should have an assessment of the uterine anatomy. The preferred technique to evaluate the uterus is transvaginal 3D ultrasound, which has a high sensitivity and specificity and can distinguish between septate uterus and bicorporeal uterus with normal cervix. So in all cases, we should not advise hysteroscopy, laparoscopy, etc. But if the condition demands, then they can be advised, and it depends on the provider. All women with RPL should not should not have 2D ultrasound to rule out adenomyosis. It is also conditional to rule out adenomyosis. Then diabetes screening is a must. It is not in the slide. Diabetes screening, if there is a high diabetes and there is chance of having diabetic embryopathy, uncontrolled high diabetes in type 1 diabetes or uncontrolled high type 2 diabetes, when there is a very high HbA1c and there is chance of having diabetic embryopathy, they can cause the recurrent pregnancy loss. Otherwise, the diabetes is mostly causes stillbirth and neonatal death. But if the patient is having uncontrolled diabetes, she must have been diagnosed previously. If not done, if the diabetes panel has not been done in the patient, she can be screened for diabetes. Then comes the microbiological cause. With many of the RPL cases, we will see there is association of infection, like there is bacterial vaginosis. In most of the cases, it is associated with bacterial vaginosis, but with there is no recommendation to routinely do the test to diagnose bacterial vaginosis. If there is symptoms like cervicitis, heavy discharge, pain or lower pain abdomen, then we can do the investigations to rule out bacterial vaginosis and pelvic inflammation. And the routine torch screening is also not recommended because the organisms in the torch screening, they can cause abortion, but they cause abortion only once. Once there is infection, after that the patient develops immunity, and next time she is not these organisms will not cause abortion. She will not be infected, and abortion there will not be any repeated abortion. So the RCOG has abandoned torch screening in RPL. And we know that syphilis and TB also can cause recurrent abortions. In the syphilis, we know the prognosis gets better. So there is less chance that it will cause repeated abortions, but the screening for syphilis is to be done, and the screening for TB is optional for the provider. Then coming to all other factors, the male factor is also sometimes responsible for the recurrent pregnancy loss. If there is DNA fragmentation, there is more chance of recurrent pregnancy loss. So the semen should be examined for DNA fragmentation and the sperm function test. It is strongly recommended in case of RPL. Then the male partner should also be assessed for lifestyle, age, smoking, alcohol, exercise, body weight, etc. So they are also sometimes responsible for RPL, and these things can be controlled both in male and female. So these investigations are to be advised in a case of RPL. After all the investigations, in 50% of patients, we can find a cause, and when the cause is treated, there is very much increase in there is a good prognosis. But in 50% of patients, we do not get any causal cause for the RPL. We do not get. In those patients, we can tell the woman that in 50% of cases, even if no cause is found, 70% will have a live pregnancy. And the supportive care and vigilance in the next pregnancy is the most appropriate treatment, and the prognosis is excellent. So take home message is not to lose hope, and solution exists for all the problems. So thank you.
Thank you very much, Subra. Those who have questions will please post them in the chat box. Now we go on to the next, move on to the next topic, a very vital topic, out of the box again, a practical step to reduce stillbirths in Odisha, because we know that referral protocol is extremely vital, because it's our experience that a person with impending stillbirth or impending factors for stillbirth being referred to from level 1. The 108 ambulance takes her to the next site, which will be a CHC, whereas she would ideally be transferred to a medical college where there is multi-speciality service, or even or at least a very good FRU, so that this stillbirth could be prevented. So since Professor Lucy Das, she is one of the persons who has got a special acumen for these managerial issues, for which she has got an award for her brilliant services during COVID at SCB Medical College as superintendent. I have given her this topic, and so that what referral protocol would minimize the stillbirth rate in our setup, right from level 1 to level 3 tertiary multi-speciality hospital. What should be the ideal referral protocol? And hopefully followed by, or DFW will take it seriously and call a technical meeting with the MD.
We have full trends, full
We have a referral protocol as soon as possible. We've been working over it. Meena ma'am from UNICEF, she has shown her concern. We have gone pillar and post, but somehow it has to come to work, come into some system, so that this factor does not play does not hinder reducing our stillbirth rate. Professor Lucy Das, please start you've already shared your slides, and please start. And all of you, please give your opinion in the chat box as to what should be the ideal protocol according to you. Whether you agree with this, Professor Lucy Das, or whether you have to add something more, please, it's extremely important. These webinars from Center of Excellence is in the hub and spoke model, and we plan to take the state forward with us. We want to find out every loophole that can prevent MMR and IMR from coming down. Prevent from going up, so that Odisha has very poor figures and we must improve them. Thank you, Lucy, madam, please start.
Thank you, madam. Respected Shama madam and all the dignitaries present. Actually, I have searched a lot for this some ready-made protocol or some template like things, but I couldn't find. I think we have to work on it and make our own protocol template.
Madam, it is slideshow mode kindly.
Kindly put it into slideshow mode.
Full screen page.
Full screen kind.
City नहीं slide show को चल जाएगा ऊपर दिखाई ऊपर
below there is a cop.
It's okay.
Yes, it's okay.
Okay. So this definition has already been told, but just to go through, WHO defines birth of a baby weight of 500 grams or more at 22 weeks or more completed weeks of gestation, or body length 25 centimeter. But for international comparison, WHO also recommends report stillbirth with a birth weight of 1000 gram or more, 28 weeks of gestation or more, and body length 35 centimeter or more. So there are many strategies which have been laid out by Government of India to reduce the stillbirth. India accounts for 22.6% of global burden of stillbirths, and the strategies which have been already laid out, like appointment of ground level healthcare worker like ASHA, distribution of safe delivery kit, conditional cash transfer, efforts to track pregnancy, free transportation of antenatal mother, cashless healthcare scheme, and so many other strategies have been taken. And by that, the institutional delivery have increased in an exponential way, but no significant reduction in stillbirth has occurred. So somewhere something is lacking, for which we are failing to achieve our goal. So maybe in the ground level, in the grassroots level, or maybe in the tertiary care center. And we have to find out that thing, what is lacking there. so that we can achieve our goal. So as we know, in India, stillbirths are under-registered. 40% of all stillborn are early neonatal deaths that take place in labor room and the first day of birth. The World Health Assembly calls for a national SBR of less than 12 births by 2030 and the further reduction to 10 per 1,000 births by 2035. The government of India has also launched a program, the Indian Newborn Action Plan, with goal of target to achieve a stillbirth rate less than 10 by 2030. So, as we all know from this is not very clearly visible, but we can see from this slide that majority of the stillbirth, or all of the stillbirth we can say, occurs in antepartum period and intrapartum period. So, in antepartum period, the stillbirth rate is around 27%, and in intrapartum period, it is 21%. So, nearly 48% of stillbirth occurs in antepartum and intrapartum period. So, if we focus in this timing of pregnancy, we can achieve our goal, I suppose. So, we have to do a lot of work in this during antenatal and intrapartum period. So, we can prevent the stillborn and also the early neonatal death. So, again, after the strategies of Government of India, NMR has not decreased and stillbirth rate has not improved, as we can see from this picture. Then coming to referral protocol. So before going to the protocol, we must know that what we should do. We cannot just refer a patient, whoever comes to PSC or CSC, and then you go to the higher level. So before that, pre-conception counseling is very, very important. Proper antenatal care starting from the grassroots level, early recognition and effective treatment of high-risk maternal factors, prevention of preterm labors, and hygienic labor room practices, strict monitoring of labor, and partograph plotting is very, very essential. I think these factors to some extent will prevent stillbirth. So the referral protocol, I think it's not only antenatal and internatal, but pre-pregnancy condition also we have to focus to prevent stillbirth, like counseling and health checkup of newly married couple or all person who are having recurrent stillbirth have to be done. Serious diseases condition like pre-existing or from clinical history taking, if we suspect some serious disease condition, they should be referred to tertiary center for diagnosis and treatment before pregnancy, like diabetes, pre-existing diabetes, hypertension, hyperthyroid or hypothyroid, and specifically hemoglobinopathies, which is nowadays has come up in a big way. And also nutritional supplements, iron supplements, vitamin D supplements. Those are very, very important to prevent stillbirth, and it should be given pre-pregnancy level. Then referral protocol in antenatal period. So antenatal period, usually, as we know, the patients are from the villages, they come to BHND center for antenatal checkup. And as we see the patient in maternal mortality rate review we are seeing in our hospital, that many of those patients, nearly 90% of those patients, they don't have they have not completed all 4 antenatal checkups. So why they are missing this? So we have to be very, very sure that they have come every time, all 4 times for that antenatal checkup, and they have attended that PMS-MA clinics, so that we can identify the risk group there. Then at least 3 USG, if not more, like NT scan at 11 to 13, TIFA scan at 20 weeks, and a growth scan 32 to 34. This will cover majority of anomaly and placental localization, and also we can know the FGR, growth retardation, from there. And other scan, as Chinmay madam told, is also very good. But at least I think this much scan is essential to pick up the serious cases. Then I know all of you must know these red cards are being given to the patient who are high risk, but many times we see these red cards are incomplete. They are not filled. So it must be filled. From that only we can find out what are the risk factors. And this is a very, very important. In Mamata card, we have this page. And you see, everything is written. All the high-risk groups are included, all the high-risk factors. And if I think we have to stress on the A&M or the staff nurse in the PSC or CSC, that they should fill this place. And they should, this another addition should be made, where to refer in this chart. Like every individual ଅତୀତରେ ଗର୍ଭର ପ୍ରଥମ ପରିଦର୍ଶନ ବେଳେ ଆକଳନ କରନ୍ତୁ 4 ରୁ ଅଧିକ ଥର ଗର୍ଭବତୀ ହୋଇଥିଲେ କି ଆଗରୁ ଅସ୍ତ୍ରୋପଚାର ଜନିତ ପ୍ରସବ ଅନ୍ୟ କୌଣସି ଗର୍ଭାଶୟ ଜନିତ ଅସ୍ତ୍ରୋପଚାର କରାଯାଇଥିଲା କି ପୂର୍ବରୁ LBW ଶିଶୁ ଜନ୍ମ ହୋଇଥିଲା କି IGR ଶିଶୁ ଜନ୍ମ ହୋଇଥିଲା କି so ହଁ ନା ଲେଖିବେ yes or no they have to, but this page is totally blank. So this, we have to stress on this. From this only, in very grassroots level, we can diagnose which are the risk cases. Very simple to diagnose, so that they can refer to higher center. And what should be the higher center? That will make another chart, I think, here, that which higher center, in which condition, to which higher center we will refer. So this page, I think that it will go a long way to reduce stillbirths. Then in antenatal period, what are all the factors have already been told, I did not tell, but these factors are also in that chart which I showed previously. So these conditions which are there have to be addressed, have to be detected at early level, and where they should go, that we have to find out and make it available in the grassroots level in that Mamata card itself, so that the same principle they can follow. Then in SCB in 2019, a stillbirth, this analysis has been done. One thesis, Dr. Subhas has been given. And in that analysis, there was, in the 1 year, there was total delivery of 15,967. Stillbirth was 1,000. But out of which unknown cause was 64.9%. And HDP was 13.1, anemia is 5.4. Hypothyroid 5.4, jaundice is 3.3, cardiac and renal diseases are 2.9%, and other infections were 1.8%, and hemoglobinopathy is 0.6%. Nowadays, our government of India have been given stress upon these hemoglobinopathies, and HPLC is done to all patients. It is advisable rather, and if they are thalassemia or sickle cell anemia, they are detected. In our center at SCA Medical College, we are doing the chorionic villus biopsy, so that these babies, if they come out to be positive, they can be terminated at early stage. So you can refer these cases. So hemoglobinopathies can be ruled out at a very early stage, first trimester. So all these things, by analysis, we have found out, and we can see from here, apart from the cause unknown, of course, the unknown cause may be some cause which we are not able to find out, because 97.9% are referred from different hospitals. So when they came, the baby was already dead, and the mother, all the placental causes have been disappeared. Baby is already dead. There's macerated stillborn babies have been born. So we could not know what are the causes. So had they come previously, we could have found some cause. So, and in HDP and this hypothyroid, anemia, all these conditions, we can treat them beforehand. So I want to say that if these such conditions are present, we should treat them at not all the case from right from first trimester of pregnancy, they will be referred to higher center. But the person who is treating them, maybe Anganwadi worker or A&M or staff nurse or doctor in the BMOC trained doctors, whoever are treating them, they should know that these are the high risk patients I'm dealing with, and at least if not very high risk, like suppose the previous cesarean case. Previous cesarean cases can be dealt with up to 32 weeks or so if there is no other complication. But definitely after 32 weeks, she should go to a center where there is operation can be done. OT facilities are there. So because, and after 32 weeks, not at the last stage where after labor pain is occurring, because the patient should also be accustomed or should not feel that she is out of home when she goes to a higher center. So from 32 weeks, if she attend that center, higher center, she will be acquainted. and she will know who is the doctor doing. So while she reach in the dead of the night, there will not be any much a problem for her. And as we know, this intrapartum causes are fetal distress, prolonged labor, obstetric labor. So this in intrapartum period, in labor, during labor pain, these cases are which are mostly referred to tertiary centers. And these cases mainly should be referred where there is extensive facilities. So to save fetal life, in case of fetal distress and prolonged labor where fetus is very much in distress, the essential facilities are very much required. So many now the district headquarter hospitals have come up and new medical colleges have come up. So essential facilities should be strengthened in all these areas so that the referral will be minimum to old medical colleges, which is still occurring. Even the eclampsia cases, we are seeing that medical colleges are also referring, in spite of having ICU there, they are referring to us, which should not be done, because on the way we are losing so much of time, and the patient could have been managed and she could have been saved also. The baby could have been saved, mother could have been saved. So strengthening of in triaging is a very important place, because as soon as the patient come there, we should know where to go and prompt action should be taken. Suppose there is fetal distress, so immediately do the hydration and take the OT and take out the baby. And even obstructed labor, we have to similarly act promptly so that baby can be saved. Then, but while sending the patient to higher center, patograph definitely has to be sent, and it has to be done by all places, all pregnancy point, delivery point, patograph has to be done, and while referring, that has to be sent. And doctor of the referring institute or higher center has to be contacted. So I think some provision may be made where the phone number of all the labor rooms should be connected. So where they are going, they should call beforehand, and the doctor should know that this type of patient is coming, so that they can act more promptly. And before sending a patient like chorioamnitis, obstructed labor, antibiotic one shot should be given. Like we are giving, Government of India recommended ampicillin, gentamicin, we should give and say. Similarly, eclampsia patient, 5 gram IM in each buttock to be given to prevent convulsion. Unconscious patient, mouth gag has to be given, and oxygen inhalation in 108 also it is present. So we have to ensure that. Then hypertensive patient, hypertensive drugs should be given to eclampsia patient, and antibiotics I told you we have to give. And then antenatal patient in shock, NASG kit should be applied and then sent, IV line to be secured. And in all cases, treatment given should be recorded in referral slip. The referral slip is there in every place. So all detailed treatment has to be written in referral slip. And I think the ALS, not only 108, the ALS also should be placed in every headquarter hospital, at least when they are sending to still higher center, tertiary center like old medical colleges. ALS ambulance is better because they have intubation facilities also. So that will save much more this fetal and maternal complication will be lesser still. Then stillborn can be prevented. So lastly, I want to tell stillborn can be prevented by premarital diagnosis of maternal diseases and prompt treatment, identification of high-risk groups and referring them to higher center for treatment, and delivery of high-risk patient by competent hand in high-risk facilities. When patient reaches from a low-risk, from a periphery to a tertiary center, that means the patient on the way has already condition has deteriorated. So immediately some senior faculty has to look upon the case, not that we have to leave to all the juniors only, and then when they are called, we will go. So everybody has to rush together to save the life of the patient and the life of the baby. Thank you all.
Thank you, Lucy Madam, for your very comprehensive approach to the topic on referral protocol for stillbirths. Now, has DFW joined? No, not yet. So before we go on to a very important topic by Professor Ajit Naik, I just want to expose you all to a small out-of-the-box thinking regarding one individual in all of the 12 rights for the pregnant woman. In respectful maternity care, we have 12 rights. We have taken from the when human rights approach was, wait, I'll share my slides. Hello, am I audible? Hello?
Yes, madam, you are audible.
So,
Yes, ma'am, audible.
during COVID, we went online from the Center of Excellence to all the 30 district headquarter hospitals, including the RGH and Capital Hospital. And we had several questionnaires. We wanted to give, because just before that, our MD NHM, the then MD NHM Shalini madam, she was worried that we had given so many non-pneumatic anti-shock garments to the whole state, and it is not being utilized. So it was procured in 1919, but it was not yet utilized. So it was during COVID that we took it upon ourselves to sensitize on use of non-pneumatic anti-shock garments and train them up, so that we took data from all the district headquarters as to whether these were used or not. And I must thank Saroj Panigrahi, the RMNCHA consultant, along with for having contact with all the managerial staff of all the 32 tertiary centers of the state for finding out this. Then again, with that, we wanted to find out whether steps were taken for preventing another killer, the hypertensive disorders, whether before 16 weeks of pregnancy, steps were taken to identify risk factors as per gestosis scoring, and whether aspirin was being implemented or not. Then we went into attempts at reducing sepsis. Then newborn care also, many pediatricians joined us, including Nirmala Di, and then Vijay Sadangi was again constantly present with us in these setup. Then one of the questions we asked was the role of a birth companion. Were the birth companions being involved, and at what stage? So at least about 80%, we found that some birth companions were there, but they came only at the triage. None of the birth companions were identified before that, during antenatal period. And in one, it was horrendous to note that one particular headquarter hospital did not know what a birth companion meant. So I'll tell you that after I had retired, and of course, during the EMOC training in Vellore, we were told that human rights approach was finally the last weapon to reduce maternal mortality throughout the world. And the White Ribbons Alliance was the support for this. And when India took it up, it was White Ribbons Alliance India. And in India now we have 12 rights. Of these 12 rights, it is the birth companion, which is the third right, which is vital to preventing not only just stillbirths, it is vital to reducing MMR, IMR, and we will, as we go through these few slides, you will be convinced because of that. So, of the respectful maternity care, we knew that human rights approach finally, because Lakshya includes respectful maternity care, and it is a
share the slides, madam.
Hello?
Slides are not being shared.
I have shared the slides. Nobody can see the slides.
Yeah, nobody can see.
How? I've just
check.
Just wait.
I thought we were discussing, ma'am.
Nobody can see my slides?
No, madam, slide not visible.
Slides not visible.
Sorry. Sorry.
No problem. You can share
No,
now.
no. Now can you see?
Yes, yes, madam. It's coming up. Thank you, madam.
Yes, ma'am. Yes, ma'am.
Sorry.
Just make it a slideshow.
Yes, I've made it a slideshow now, I think. It's a slideshow.
Yes, madam. Yes, madam.
It is a slideshow.
So of all the 12 rights that WRI has taken up, we found that the third right, companion being present right from the first antenatal visit, is vital to achieving all our goals in maternal and child health that we have in the state. And this third right spells out as everyone has a right to a companion of their choice and preference during maternity care, not just in the outdoor, not just in the labor room, which we found that only during COVID, even till now, I don't know, even in SCB, we have tried our level best to sensitize the whole department for involving the birth companion right from the antenatal outdoor. Just walk in, and in the antenatal outdoor, the birth companion is not there. So things, we know certain things, but to carry it out, requires inner commitment. That means actually, if you really took this up very seriously, you would be committed to do what actually we have to get the best results for our state in the maternal and neonatal area. MMR and IMR to be reduced to the minimum. So no one is allowed to refuse your birth companion. Every woman has a right to a birth companion during maternity care. Every newborn has a right to be with parent or guardian during their stay in a facility. Okay, then as we see, Lakshya, respectful maternity care reduces preventable maternal and newborn mortality, morbidity, and stillbirths associated with care around delivery in labor room and maternity OT. And you have to ensure RMC, otherwise it's a knockout factor. In the IEC campaign to promote birth companion, the patient and RMC and patient satisfaction during maternity care services. In rapid improvement event cycle, presence of birth companion during delivery and RMC has to be included in every activity for preparing for Lakshya. This has to be done, and we cannot just underplay. And how a birth companion helps, let us now investigate. So there are certain performance standards for a birth companion. They should be next of kin, and they should be if they are, of course, in LDR setup, you can have the husband there, but in most labor rooms, you have to have the birth companion who is next of kin, who is wearing clean clothes, who is free from infections, and who has an identification tag. And remember why she is important, because she's an extra hand for us. You simply have to tell her signs and symptoms that she needs to observe and report immediately to the staff. These signs and symptoms not only should be in the labor room, but also should be sensitized to her right from the antenatal outdoor. And in the labor room, she should offer emotional support to the woman during labor, help her to move around as she desires, talk to her and provide comfort as required in the form of back massage, warm compresses, playing music, etc. So non-pharmacological pain relief is the order of the day. If you give pharmacological agents, they can cause fetal distress, they can lead to stillbirths. So now in the best labor room practices, non-pharmacological pain relief is the order of the day, and they work wonders. So involvement of birth companion in the antenatal, how does it prevent? You have heard Chinmay madam talking of the gravidogram. Now gravidogram has to be implemented wherever I have been to the different setups. I have taken a set of gravidogram and a checklist of the daily fetal movement count chart, which wonderfully Chinmay madam has displayed. These are low cost things. They don't cost at all. And if you implement them, you can detect, you can catch hold of fetal growth restriction much earlier. Now WHO recommends having a gravidogram. And this was also discussed at JIPMER in the when we gave our inputs for reducing, preventing stillbirths. The use of a gravidogram was unanimously accepted. During general as well as obstetric examination, symphysiofundal measurement, maintaining a gravidogram is mandatory, and this has to be shared with the birth companion. She will see the graph, she will be pointed out, she will be given the graph to bring it back the next time with her pregnant woman. And while counseling, you have to involve the birth companion in the antenatal chamber and tutor her regarding the importance of this gravidogram, that tell her that this is showing whether the fetus in her in a daughter-in-law or a daughter is growing well. So pictorially, it is very easy to convince her, and she becomes a part of the whole system of seeing that the fetus is growing well. Advise and follow up on high-risk pregnancies. All of the points that you would tell the patient just mechanically, you have to share it with the birth companion, and she would know it, and she would know when to all the other high risk factors also, along with the gravidogram. Then involve her in maintaining the daily fetal movement count. Just as Chinmay madam showed, just after breakfast, how many times the fetal moves and then stops, then moves and stops. Just 3 columns the patient, the pregnant woman has to fill up. And if the birth companion is also brought into confidence, she will see that her daughter or daughter-in-law does this every day. So involving her strengthens the procedure, and we gain by it by preventing, so that we can detect reduced fetal movement. And then we have seen what protocol you have to follow once there is reduced fetal movement, where to take her up. And as per our referral protocol, we take her up there and we can save this baby. So right from the grassroots, it is extremely important, because we miss out here. It is the unexplained stillbirths. It is missed out right from the grassroots here. It doesn't cost anything. It simply is the sensitization at the grassroots levels at every facility, right from the VHSND, right from delivery points, FRUs, medical colleges, wherever an antenatal care is given, antenatal chamber is there, this has to start from there. Okay, then this was a Cochrane meta-analysis done in 2013 on 22 trials of 15,000 women. Just see what the results were. The presence of the birth companion reduced the use of analgesia anesthesia during labor by 21%, which is extremely important for reducing stillbirth. Then prolonged labor was reduced by 95%. So she knows when the partograph has to be plotted, she has to be shown the partograph, and if there are shortage of hands, she will say that she will recall you that when the partograph has to be plotted, and prevent 95% reduction in prolonged labor would definitely definitely is a factor in reducing stillbirth rate. Everybody will agree in this webinar, all those who are attending. Let's see. The feeling of tension and anxiety during labor is reduced by 20%. So yes, yes. Please, can you unmute? Please, can you mute and put your questions in the chat box? So these are the 3 red highlighted area that a birth companion can contribute in preventing stillbirths. Now, I would like to see this video. This we have taken from DC3, Mr. Ashok Naik.
No audio in the video.
Yes. There is an audio. Can't hear.
Not audible.
How?
Not audible.
At least see the video.
Only video is playing. Audio is not audible.
How come?
But it's written in there,
It's
sir. We can see that.
self-explanatory also.
That is there, but the audio is not there.
I think madam has to share sound. That is an option that comes in the video.
Where?
Yours it is audible.
No, we can't hear, sir. When madam shares, no, she
can
has
I
to
make,
share it with sound.
Madam has to share it.
That one, ma'am.
Can you hear now?
No, ma'am. Actually, in
not
the Zoom link, no, when you are sharing your screen, at that time only there will be an option of share sound. It's okay, ma'am. We can see.
Okay, we can.
I'm so sorry.
No problem, ma'am. Maybe you can share in the group or something like that later. These methods actually have not been given their due importance. We don't identify these as, methods of pain relief. It's a very nicely done video.
Including music.
These are old techniques. Like
yes, sir.
In our early days, we saw there were dyes or some ladies, old ladies, they were assisting mothers at home. So there were not many medications available also.
Yes, sir.
So these were the practices.
Gold are always gold.
Yes, we have to come back to this and don't forget it. And in fact, it has to be implemented everywhere in all our healthcare setup. And so in brief, involve the birth companion in every antenatal visit. Okay. Help her identify risk factors in history in the first trimester for preventive role of aspirin. Tell her before 16 weeks, if we give an aspirin, your daughter-in-law is unlikely to develop that Vatamara rogo, you can tell. No, in so many, in that very raw way, you can tell. And 28 weeks onwards, tutor on the gravidogram and produce it at every antenatal. So everybody agrees with the implementing the gravidogram? Yes or no?
Yes,
Then,
madam.
Yes.
I routinely use in
means
OPD.
from tomorrow itself, all of you must use the gravidogram. Because the growth restriction, when from 50th to 10th percentile, if it is going and below that, that is the time you have to send up to the higher center and we can save these babies. Tutor on danger signals and report. We have a list of danger signals and we do not care to tell the pregnant woman about these danger signals. But if the birth companion is there, you tell her also about the danger signals. So the woman may be unconscious or blurry, and at the time the birth companion is there, she knows these danger signals are there, and I must take my daughter or daughter-in-law to the healthcare setup, and so that she and her baby will be saved. So 32 weeks onwards, involve her on daily fetal movement count chart. As Chinmay madam has shown, make a chart. We have made a chart. We are giving it to every BMOC batch. We had given it to our department. I don't know, Kirti madam, I don't know why it is not being implemented at SCB also, in spite of the fact that everybody has agreed that we should have these DFMC charts and gravidograms given to our women. And I even went forward. Please excuse me, but I feel very strongly about it if you are lackadaisical on this aspect. Nobody should be lackadaisical on having these two things, gravidograms, DFMC, involving the birth companion in every antenatal visit. These are things we can do. They're not rocket science. And yet, why aren't we doing it? And we are crying over things that Odisha is highest in stillbirth rates. If simply it touches our heart and we go forward and do these things, definitely we will improve. I don't know if anybody disagrees with me. In the labor ward, be present for non-pharmacological pain relief. So see whatever that from that video. If anybody comes around, I can I'll share it in the group later on with the video, with the audio. But non-pharmacological pain relief should be the order of the day. We should not use the pain relief drugs in the labor room, which very often we try to do when the patient shouts too much. And then sensitize on the partograph and appreciate unsatisfactory progress to the birth companion. Just show the birth companion the partograph. This is the way the labor should progress. And these are the times that the provider should come and check your pregnant woman. So if you have sensitized her, that naturally pregnant woman cannot be neglected when she's in the labor ward. So another out of the box thought, can we involve Suman volunteers in this direction? It is for, if I don't know if Ashok Naik has joined this meeting, but again, I'm going out to two places where C3 is working on Suman volunteers in Bhadrak district, in Chandbali, and in Basudevpur. In my next visit, I'll be going there and seeing actually how these Suman volunteers are working, and we will see if our mentors can also reach out to these Suman volunteers and see if right from the grassroots things are sensitized. So these are other things all of us should be sensitive about, so that we can go forward and prevent our stillbirths and also other adverse events like maternal mortality and perinatal mortality and other things. So hence, Health Team Odisha, we are all Health Team Odisha, and involve the birth companion in maternity care and reduce stillbirths. Thank you.
Madam, namaskar.
Namaskar. Now we go on to the next speaker. That is Dr. Ajit Naik. Ajit Naik will tell us, now that the baby is dead, much problem we face while dealing with the dead baby. The patient, the pregnant woman is worried, her birth companion is worried, the whole treating team is worried, and you have several methods to how to dole her out from this dead baby. If she may be a very big, large baby, 4 kg baby, and you may not be able to deliver, and maybe probably resort to a cesarean section. And of course, destructive obstetric operations are now out of practice. Yet these are certain situations where you would prevent a cesarean scar and remove the dead baby out. So Ajit, Professor Ajit Naik, everybody knows, all the students know what a great teacher he is. He's a product from JIPMER. Dr. Latha, as you will know, he's a product postgraduate from JIPMER, and he carries the JIPMERian stamp to his teaching and clinical care and approach to obstetrics and gynae. And so I have given him this topic. Ajit, please share your screen and start.
Thank you, Professor Shama Kananga, madam. All the faculties and gynecologists who are
please
online on the screen.
Make it a slideshow. Make it a slideshow.
Full screen karo.
Full screen. Click the slideshow.
Cup. Below cup.
Click the slideshow, you'll get the slides.
Ajit, niche, that one is there, no icon. You click on it next to the person.
Just in the top floor, in the top line, one,
Yeah,
two, three.
yeah, that's
That one,
it.
that one.
Fifth one. Slideshow is written. Click there.
Here
Click
also.
there or down here. The trough kind of sign. Found it, huh?
Below copy is what?
It's now okay, madam.
No,
No,
no.
No.
See, look at the top of your that icon line.
Ajit, you have to click on the slide and then click that icon, it will open. Or you have to go to the resume, go up to the slide.
Slideshow. Go see. Slideshow is written over there. Just click over it.
Yeah.
Above your slides. Slideshow. We can see.
We can see. Now it is visible, madam.
No, you click on the slideshow. It is visible, but click
visible,
on
but
the
not full
slideshow.
No, sometimes for him it will be in slideshow mode, for us it won't be. So you go out of the slides again, open it new and do that, Sajid. Kabhi problem hota hai iska.
Yeah, stop share and start sharing, and that might help.
Yeah.
Stop share. Yeah, here. Then I can say it.
totally blank हो गया.
All right.
Share screen. Yeah. Now go to the top layer. You have got slideshow written over there.
वही वाला वो नीचे था ना आपका, वहीं पे जाओ परसेंटेज के पास.
That one. Yes,
Double
yes.
click
Click that.
करो
Click
उसको.
that. Click that one.
Yes, I have clicked. Now it is coming.
नहीं आ रहा है ना. नहीं, सेटिंग्स में कुछ किया होगा तुमने.
नीचे डबल क्लिक करो ना कप में.
He's telling it's not coming.
सर
तो
ऊपर टूल बार रे
जाके
सर
स्लाइड शो से कर, ऊपर स्लाइड शो से करो.
ऊपर टूल बार ऊपर है सर.
After animations on slideshow is there, no?
हाँ.
Toolbar.
Insert, design, animation, slideshow. ऊपर ଅଛି. ऊपर टूल बार पाखरे ଅଛି.
ठीक है.
सर पूरा बंद हो गला.
अंधार कर देला.
ଆଉ ଥରେ स्टॉप शेयर करी पूरे. हाँ शेयर. हाँ, रिज्यूम स्लाइड शो ऊपर लिखा है ना वहां.
ब्लैक बार
स्लाइड शो, रिज्यूम स्लाइड शो देखो ऊपर लिखा है.
नहीं तो नीचे जाओ, नीचे कप में करो ना.
एक बार और स्टॉप एंड स्टार्ट करो, हो जाएगा.
Okay, you continue. You don't waste time.
Share screen and continue same way. No need. No need for screen share. No need for that slideshow. Just share screen once more and go ahead.
Now it's visible.
Go ahead.
Okay, go ahead.
Go ahead. Go to the next slide. Go to the next slide. No problem.
Okay, madam.
We can see both.
Okay. Thank you. So already we have discussed the definition of the fetal device, and before proceeding for termination or delivery or induction of labor, diagnosis should be 100% and it should be confirmed by ultrasound, and if required, we should take the help of the Doppler before induction of labor or termination. So coming to the management of intrauterine fetal device, number one is patient support, which include emotional support and clear communication of the test results to the patient and her attendant, and bereavement care, emotional intelligence. Necessary investigations has to be done before termination. Next is induction of labor or delivery, then postpartum care and family planning counseling. So coming to the bereavement care, it should be individualized to recognize bereaved parents' personal, cultural, or religious needs. These are the components: good communication, shared decision making, recognition of the parenthood, acknowledgement of partners and families' grief, acknowledgement that grief is individual, awareness of burials, cremations, and funerals, ongoing emotional and practical support. So referral to a counselor, to peer support group or mental health professional may be advisable. Feeling of guilt or anger in parents who have experienced a stillbirth are common and may be managed when there is an abnormal child, magnified when there is an abnormal child or genetic defect. However, some parents may welcome discussion and find relief in autopsy result. The results of the test are important even when no specific diagnosis is identified. Next comes the autopsy, placental examination, laboratory test, and cytological studies. The result of the autopsy, placental examination, laboratory test, cytogenetic studies should be communicated to the involved clinician and to the family of the deceased infant in a timely manner. If there was no growth of fetal chromosomes, further consultations with a genetic or maternal fetal consultant is advised to discuss the need of parental chromosomal testing. A copy of the result of the test and list of diagnosis excluded should be provided to the patient desired. Next, the emotional intelligence for the patient. A stillbirth is a catastrophic event. A delivery, if a name has been chosen, the baby should be addressed by their name. There should be a contact between the mother and stillborn. The patient family should be counseled well before delivery on the things for which they need to prepare. Developing a connection with baby makes the death real, helps prevents emotional withdrawal from the loss, and helps in the transition to parenthood. In some studies, encouraging contact with the stillborn has been linked to post-traumatic stress, anxiety, and depression. It is a controversial issue. Counseling regarding autopsy should be done in a very respectful manner, which allows the family to understand its purpose and timescale. The option for autopsy, its benefit and cost must be presented in a sensitive, informative, and in a non-biased information. Coming to the management proper, we have to go for investigations. The management can be expectant, can be medical method, or it can be a surgical method or cesarean section. So these investigations are ultrasound to confirm the fetal demise, placental localization to rule out major degree of placenta previa or abruptio placentae, amniotic fluid index, expected fetal weight, lie and presentation, complete blood count, peripheral smear comment, grouping, archetyping, blood sugar, SbA1c, thyroid, viral markers, urine routine culture, urea, creatinine, LFT. Coagulation profile is very important, which include PTINR, FPTT, and serum fibrinol level estimation. Now, regarding delivery, discussion on the mode of delivery will depend upon the period of gestation, the desire of the patient, the physical status of the patient, and prior obstetric or surgical history. Information is provided, presented clearly, concisely, and confirmation of understanding should be obtained. Coagulation abnormalities can occur, and this occur in 2%. And if there is a coagulation abnormality, immediate intervention has to be done. Usually, a vaginal delivery is the safest route of delivery, even after a previous lower segment cesarean delivery, as Professor Sama Madam told. They can use destructive operation also. Some women may request a primary or repeat cesarean section to avoid experiencing labor. There is an option provided the patient is fully aware of the risk versus benefit. So stillbirth after 28 weeks with a favorable cervix, Bishop score more than 6, we should go for oxytocin infusion. If the Bishop score is less than 6, without any scar in the uterus, we can use vaginal misoprostol 50 microgram every 4 hourly with a maximum of 6 doses. If the first dose does not result in a cervical changes or after 2 contractions in 10 minutes, the second dose can be doubled from 50 to 100 vaginally, and it can be again doubled 200 4 hours after the 100 microgram dose, and the mean time to delivery interval is around 10 to 12 hours. If the delivery does not occur in 24 hours, the same regime can be repeated once only. If it's failed, or if dilatation is more than 4 centimeters, we can use oxytocin infusion. Now, misoprostol is not repeated if there is a greater than 2 contraction in 10 minutes because there is a risk of tachycystole or there may be chance of uterine rupture. Now, the expectant management, as we know, 80% of the cases, there is a chance of spontaneous expulsion within 14 days. Women with intact membrane, no evidence of DIC, sepsis, or preeclampsia with severe feature may remain at home with advice to come to hospital for planned delivery. DIC profile, particularly serum fibrinogen estimation, has to be done twice a week to rule out DIC. So the reason for early delivery is reliable and early diagnosis could be made with real-time ultrasound. And nowadays prostaglandins are available for effective induction of labor, and complications like DIC, sepsis could be avoided if we intervene early. So indication of early interference, one is psychological upset of the patient because he is carrying a dead baby, manifestation of the uterine infection, and tendency of prolongation of pregnancy beyond 2 weeks, and there is a chance of failing serum fibrinogen level, which is though rare. So methods of delivery should always be done by a medical inductions. Already I told combination of mifepristone and prostaglandin, particularly misoprostol, recommended as the first line choice for induction of labor. A single dose of 200 milligram of oral mifepristone and misoprostol vaginal 25 microgram 4 hourly are safe, effective, of low cost with induction delivery interval of around 8 hours. Or we can use mifepristone 600 milligram daily for 2 days, also can be used for induction of labor in IVFD. A meta-analysis of 14 randomized controlled trials that evaluated methods of induction for second and third trimester stillbirth demonstrated that both vaginal and oral misoprostol were 100% effective in achieving the uterine evacuation within 48 hours. Mifepristone 200 or 600 milligram orally can be used as an adjunct to misoprostol for induction of labor in the setting of stillbirth because it reduces the time to delivery when compared with misoprostol alone. However, it does not appear to increase the efficacy of induction. When available, mifepristone can be administered 24 to 48 hours before initiation of induction with misoprostol. So misoprostol can be given vaginally or orally. Vaginal route is more preferred. It can be repeated every 4 hourly. And if misoprostol after dilatation, we can use after 4 hours of misoprostol, we can use oxytocin also, or we can use in scarred uterus, that is dinoprostone gel, PGE2 gel in the posterior pharynx of the vagina. That can be repeated 6 to 8 hourly, and it can be supplemented with oxytocin infusion.
Professor, sir.
Hello. So oxytocin infusion is widely practiced.
You can speak after the speaker has completed, or put your queries in the chat box.
So oxytocin infusion is a time-tested drug for the induction and termination labor in IUD. Before the discovery of these prostaglandins, it is widely practiced and effective in case where the cervix is favorable, Bishop score more than 6. To begin, we have to add 5 to 10 units of oxytocin in 1 bottle of ringer lactate and administered through the IV drip. In case of failure, there is an escalating dose of oxytocin. That means in 1 bottle of RL, you add 5 units, then after 15 ml gone, then you can add another 5 units. That like that, we can give the escalating dose. To start with a drip, you set up 20 units of oxytocins and run at the rate of 30 drops per minute. Oxytocin infusion is used as a supplementary therapy. When vaginal prostaglandins, particularly misoprostols, are used, one should exclude the possibility of secondary abdominal pregnancy if repeated attempts fail to start the labor after oxytocin infusion. So management of IUD in a case of previous scarred uterus, therefore based on limited data in patient with 1 previous cesarean section, trial of labor remains a favorable option. There are limited data to guide clinical practice in patient with a previous classical cesarean delivery or multiple previous cesarean delivery, and the delivery plan should be individualized based on individual circumstances and patient preference. In women with increased risk of uterine rupture, like hysterectomy or any transpondal surgery, repeat cesarean delivery is a reasonable option. Women with increased risk of uterine rupture who opt for induction of labor should do so with an understanding of the increased risk. The healthcare providers need to be attuned to signs and symptoms of rupture throughout the labor. That means labor process has to be monitored very carefully if you are allowing induction in a scarred uterus. Now, management, women with third trimester fetal demise and unfavorable cervix, a prior history of cesarean section should use a mechanical method of cervical ripening by using a Follis balloon, which is a very time-tested to increase the Bishop score and followed by oxytocin infusion for induction, and it does not have tachycystole or chance of uterine rupture. It's a very good option in a scarred uterus. Misoprostol may be considered as an option only after rigorous informed consent. So we have to counsel the patient repeatedly before using misoprostol in a case of prior history of cesarean section, and lowest possible dose should be used with minimal frequent interval to prevent the tachycystole and rupture of the uterus. Women with third, then come the management of IUD in previous hysterectomy operations. Then women with a previous hysterectomy operation and fetal demise after 28 weeks should undergo induction of labor as per standard obstetric protocol for trial of labor after cesarean rather than misoprostol. So we can go for trial. We may not use misoprostol in these cases. Then in patient after 20 weeks of gestation, a previous hysterectomy, we can try for cervical ripening with trans-cervical Follis catheter is associated with uterine rupture and is comparable to a uterus which have no scar. So trans-cervical Follis catheter mechanical induction of labor is a very good option in case of a scarred uterus. Then comes use of prostaglandin E2 gel, which is an option alternative to misoprostol, particularly in previous 1 LACS, because chance of tachycystole and chance of uterine rupture is less in PGE2 gel compared to prostaglandin E1 or misoprostol. So management of the IUD in fetopelvic disproportion, in macrosomia, transverse lie, or shoulder presentation. Fetopelvic disproportion seldom is a concern for delivery of a stillborn, whether breech or cephalic in the absence of macrosomia. If there is a macrosomia, we have to think twice before going for cesarean section. Because overlapping of the skull bones, fetal deterioration allow the delivery even of a large fetus of more than 3.54 kg. A persistent shoulder or transverse lie may require an internal or external version where cesarean section can be avoided. If unusefulness, this fetal presentation may require sometimes cesarean delivery. Now, indication of CS with scarred uterus, number 1 is previous to or more cesarean is an absolute indication for cesarean. Number 2, history of classical hysterectomy or transfundal surgery, or there is a major degree of placenta previa. These are the 3 main indications of cesarean in a scarred uterus with IUFD. Now, postpartum suppression of lactation, counseling regarding breast engorgement, which may lead to physical and emotional pain, is essential. Some mothers will request information on how to stall milk production as quickly as possible, while other women wish to consider donating milk helpful emotionally. And if they want to suppress the lactation, as we know, capargolin 0.5 milligram 2 dose should be started as early as possible after delivery of the fetus. Now, family planning is a very important aspect after the delivery of a dead fetus. At an appropriate time, concerns regarding family planning and future pregnancy may be discussed. An inter-pregnancy interval of fewer than 6 months is not associated with an adverse pregnancy outcome in the next pregnancy. Women and couple are counseled that they may try to become pregnant whenever they are ready. Now, medical team and nursing staff should be provided all the support and sympathy to the family. Couple should be explained in simple terms about the possible cause of fetal death. A psychologist or counselor may see them to support. Recovery in postpartum ward is better avoided. They should be isolated. Risk of postpartum depression is high. Couple to attend postpartum clinic after 6 weeks regarding the postpartum checkup and also to further investigations. Family planning counseling. Investigation reports are reviewed and counseling for future pregnancy is to be done. So thank you all for listening, sharing. Thank you again.
Very much. Thank you very much, Ajit, for
Thank you, madam.
a very comprehensive presentation and different situational analysis and on different methods of induction. Anybody has any questions, please post them in the chat box for reply by the speaker. Now we go on to a very important aspect which will be dealt with by our RMNCHA consultant, Mr. Saroj Panigrahi. He will be talking to us on stillbirth registry and reporting, because most of the situation we include early neonatal death into the stillbirth. So for fearing, this is a human problem. We all know it, but we oversee it. So we have to be honest in reporting actual stillbirths, because this may be one of the reasons why Odisha's stillbirth rate is so high. Maybe some of the early neonatal deaths have been included in stillbirth. So how to go about it, how to actually register the stillbirth and how to report these stillbirths at all delivery point levels. We would like our RMNCHA consultant, Shri Saroj Panigrahi, please kindly unshare your slides, Ajit. Unshare your slides so that Saroj can share his slides.
Madam, namaskar.
Wait.
Madam, smooth. Madam, I have not prepared any slide.
Okay, then you.
I'm telling because I am on a tour for this kayakalp assessment. So I am telling that this reporting is highly important for the purpose of this health system planning.
Please,
hello.
Start your video, please.
Video. Let us see you speaking.
Ma'am.
I told you this well in advance. So I prepare. Okay, go ahead.
Yeah, ma'am. Actually, what happened is this stillbirth presently, ma'am, we are reporting only two types of stillbirths. That is, one is macerated and one is the fresh stillbirth. In HMS also, we have only two types of reporting, but we are not recording any cause of death or whether it is an early neonatal death or it is a live birth and we are putting it in a stillbirth. We don't have any mechanism also to report such things. So that is why now the state is planning for an audit, this survey, this research or the study that what to do under the circumstances where they are reporting that it is a live birth as a stillbirth. But the thing that you have told that the presence of birth companion, they can be taken as a important aspect for such activities because this birth companion is present during the delivery and she is seeing whether the birth is a live birth or stillbirth or whatever it may be. She can give her input for so that input can be taken as an evidence that whether that birth is a stillbirth or live birth. And I suggest, ma'am, we have to sit as a technical person should sit, and we should improve or we should recommend some mechanism to improve the reporting system in HMS also, as well as because the nursing officers and the doctor, particularly the nursing officers who are delivering the baby in the labor room, for avoiding the problem, they are reporting them as a stillbirth. But we should instead them not those live births stillbirth because it is basically giving personal rate is maximum, almost around 21,000 live births. So that is why we need to establish an improvement or strengthening the reporting system so that the system will strengthen and will get the accurate data what is happening in the labor room or the field about the stillbirth. And if we get the accurate data, then only we can plan or we can make policy for strengthening of such like stillbirth system or stillbirth to. Thank you, madam.
Thank you. Now we go on to what we can learn from people who have actually have had a specific strategy. And we know that Shweta madam from AIMS, she's the head of the department of OBGYN in All India Institute, Bhubaneswar, at Bhubaneswar. Sorry, and she is in charge of the stillbirth, the prevention of stillbirth in her institution. So we would like to listen from Dr. Shweta. Shweta, please. Have you any slides to show us?
Yes, thank you, madam. I'll share my screen now.
Shweta is an illustrious person with many rewards to her credit. She's got experience from across, from abroad, from UK, and she has won many rewards. And at present, she is the representative from Odisha in the Fetal Medicine Society for Fetal Medicine. There is a yes, yeah.
Okay, ma'am,
She's,
are my slides visible?
Yes, yes. She is member
Okay,
of
and the
WHO
slides
Technical
are
Committee.
moving.
Please let people see what you are. This the previous one, please. Technical Working Group on Burden of Birth Defects. Then she's secretary, of course, SFM Odisha, and she's also been re-elected as a to the Central Committee of SFM, and she's won all these awards, and then she's got 90 publications, and she's a reviewer for 6 journals. And of course, we are very happy that she was one of our trainers in ultrasound when we went across to the whole state with Dr. Hashmukhlal giving us all the SUAB guidelines for basic ultrasound in obstetrics and gynae. Shweta was with us and she also imparted training, but being held up by her institutional, I mean, sort of framework, she couldn't come out as a mentor, on-site mentor. But then all the same, she's there with us to share. So Shweta, please, you have done something to prevent stillbirths and you are doing something out there. And we hopefully your experience will help us all out here in the community and the headquarters and the hospitals. Shweta,
okay, thank you
go
so
ahead.
much, madam. Good evening, everyone. Thank you, Shama, madam, for giving me this opportunity. We all consider madam as our teacher. So, I was assigned this topic, strategies in preventing stillbirths experience at AIIMS Bhubaneswar. So before we can prevent something, we should know what are the causes of the same in our state. And this is the NBBD, Newborn Birth Defects Database, which in collaboration with WHO, AIIMS Bhubaneswar is reporting its data on stillbirths and birth defects, as well as when we went for training, SCB had also gone, so I'm not sure whether they are still reporting or not. But this is the NBBD database to which we report all the stillbirths that we receive, whether it is intramural or extramural. Now, 55 centers in the country are reporting stillbirths to the WHO CDC, which is in collaboration with the Ministry of Health and Family Welfare, Government of India. And for these 55 centers, stillbirths is defined at more than 22 weeks of gestation, not 28. It is only for these 55 sites, but for all others, it is 28 weeks, and that's fine because it prevents, a lot of doctors from being blamed. Or if gestational age is not known, a fetus born with no signs of life beyond 500 grams. So, because there was a discussion on what we are not reporting, so in this database, basic information, pregnancy details, examination details, details of the stillbirth, and any attachments like autopsy reports. We do routine autopsy if the patient party agrees to it. Photographs, etc., can also be uploaded, and this was from 2019. So basic information like the date, maternal age, intramural or extramural. Most of our stillborns or the stillbirths are extramural, which is it did not happen at AIIMS Bhubaneswar, but with stillbirth, the patient was referred. Then the pregnancy details, antenatal care received, the number, the quality, the basic investigations done or not. Then when we have received, what are the examination, delivery details, birth details, etc. This has to be all filled up in this portal. So details, this is what we were discussing, but these are all whatever is contributing, whatever is the cause. These are drop-down menu. So we select and then go down and select what exactly has been the cause that we feel and what were the associated causes. So in between, I think this was a analysis from 2020, because at the end of the year, we could look for the analysis that what was the data. So we found that majority of the stillbirths, 77%, were beyond 28 weeks. Now, all of us would have problems of survival from 22 to 26 weeks around, but beyond 28 weeks, these babies are all salvageable. So most of these babies we see have been salvageable babies. And in terms of weight also, more than 1,000 grammars were the majority, which was 63%. Very large babies were less, but yes, more than 1,000 grammars were more than 60%. It reports, it does not differentiate whether it is what we call as an IUFD, intrauterine fetal death, or it is a fresh stillborn. Both are taken as stillbirth. That is, any baby born without any sign of life is taken as a stillborn. So fresh stillbirths were very less. There were 9 contributing to 25%. And of these, why the stillbirths happened? Fresh stillborns were obstructed labor, ruptured uterus, fetal distress, and did not receive OT in time and then was referred, etc. Fever, but abruption, 5 causes. So 5 cases. So in these cases of abruption, probably we are not able to, some babies we are able to salvage, but not all may be salvageable. So that part may probably be cannot be prevented, or a lot of effort further needs to go into it. But when we come to the intrauterine fetal deaths, what we found, anemia was a contributory factor in almost like over 44%, or over 40%. These big killers, we did not talk of the 5 giant killers in stillbirths, but hypertension complicating pregnancy, diabetes complicating pregnancy, fetal growth restriction, we had a very good lecture, and antepartum hemorrhage. So together these make up 72%. So if we are able to target our strategies to good management of these 4 diseases, I think we are able to reduce the number of the stillbirths in the state. Anemia also, anemia correction, multiple pregnancy was only 8.3%. We have so many webinars, conferences, managing twin, monochorionic, but they contribute hardly to less than 10%. And these IUFDs, which happen antenatally, these were the majority of the stillbirths that happened. So this is the Government of India key interventions, which have been known to reduce stillbirths. Of the 10, 4 which are very important: periconceptional folic acid fortification, malaria and all has been brought under control in our state a lot, syphilis detection, management, detection, and then the adequate management of hypertension in pregnancy, diabetes, fetal growth restriction. Now this is on an all India level basis, Government of India national level. Let us see at what we are able to do in our state level. So what we do at AIIMS Bhubaneswar, it's a very simple 7-pronged approach which I have brought, which caters to each of, the majority of the cases. One is in this, I have not shown the table here because I have been allotted only 5 minutes, but the stillbirths, 3 of them were associated with anencephaly or some cause of, even at term in this day and age in our state, anencephaly at term. So preconceptional and first trimester, 3 cases out of 36 in that interim analysis were associated with a birth defect. So this is a very simple way of preventing stillbirths, that you give preconceptional and first trimester folic acid tablets to all. It's very surprising that even women from educated families are not receiving it, probably due to a lack of knowledge as well as stigma that they should not be revealing their pregnancies. So this is number 1. This is very sad when we receive term, anencephalies, and then we have to deliver them. And I don't know whether I should say by grace of God, but at least born stillbirth, and we don't have to wait for the baby to, really not survive before our eyes. So we still have got this. The second is because anemia contributes to 44% of the stillborn. So anemia in any way prevalent everywhere. So do a hemoglobin test at least 3 times during each pregnancy. Give IFA tablets to all. They ask whether you should have the ones from private sector or the ones given by the government. Please have the ones from the government. They are very pure forms, very good ones. And if the hemoglobin is less, HPLC is being done for all. If it is iron deficiency, after all iron studies, we give iron sucrose 3 to 5 doses, whatever may be required, and the rest would go in the intranatal management. So improving the anemia status in pregnancy not only improves the maternal condition and neonatal, also the fetal condition, and prevents stillbirth. I think that answer also we need to be looking for. Then coming to the hypertensive disorders in pregnancy, now these we find that they have been pretty much inadequately managed at a lot of the peripheral centers. So sometimes we find that blood pressures have been monitored, but nothing has been done. And when they are referred later, by that time the fetus has already died. So very important is that in the early pregnancy, whatever screening you do, gestosis scoring is a very simple method. There are other methods also. So do a screening. If she falls into the high risk, start them on low dose aspirin. So nowadays we start straight away 150 milligram. Unless she is very low body weight, then we start 75. So between 14 to 16 weeks, screen. If they are high risk for preeclampsia, give them aspirin as well as calcium. And this is what I have found in whatever we the database that we upload and what it sends us, that termination of pregnancy, which ideally in maternal interest should be done by 37 weeks, but many times they come at 39, 40, even post dated 41 weeks. So definitely preeclampsia, eclampsia all would be there. So these cases where there has been hypertension in pregnancy, definitely by 37 weeks, at least for maternal interest, and now we know it will phase, it will prevent the stillbirths also. So definitely by 37 weeks, nowadays we are finding even 28, 29 weeks we have to terminate, because even with 3 antihypertensives, they don't respond. The third is good. The next one is, adequate management, diagnosis and management of gestational diabetes mellitus complicating pregnancy. So we know detection, you do twice. Now Government of India has made twice, but we are still following 3 times. We know the values. Start them on MNT. Advise them for buying the glucometer if you do not have supplies, and doing the self-monitoring blood glucose. Even the strata of women that we receive, some of them, we are able to convince them to buy the glucometer and teach them how to do the self-monitoring blood glucose, and they do come back to us with the sugar levels and they are much happier. So if the sugars are uncontrolled as per the guidelines, we prefer insulin. But if she is not able to come back or does not have facility or is afraid to take, there's no one to give them, nowadays we add metformin also. But very important is to achieve adequate glycemic control, and these cases again should not go post dated. Depending on what she is receiving, anything from 38 to 40 weeks we terminate them. So these cases also should not be going post dated. Especially sometimes, babies can be growing very well, there is no FGR, which should not be also in diabetes, but you find they land up with sudden stillbirths. It's because the rate of growth has been very high, and it supersedes the placental capability of supplying. So we have to be careful about these things and tell the woman also these things may be happening. This, I'm very glad, has already been discussed. So what we follow for FGR is, you follow the Barcelona protocol, you do the biometry, you do the Dopplers, you diagnose whether it is FGR or not. Gravidogram is a very good idea, but we found that it is not really the best. So depending, because we do free scans for all women who come to our antenatal clinic. So take some time. If you have residents, very good. They are also train them, they are able to do. So do the biometries, do the Dopplers. You see whether FGR is present or not, and then manage accordingly depending on the stage. So stage 1 also, definitely you do a labor induction by 37 weeks. Very selectively under monitoring, maybe 38 weeks or 39 weeks, you're able to take them. But in maternal interest, in fetal interest, we say by 37 weeks, let us admit them and then plan for delivery, because induction protocols also take 3 to 4 days. Absent flows, then there is no choice. From 34 weeks, if there is absent, you need to deliver them. Reversal of flow 30 weeks onwards, and all these preterm ones, we need to go for a section. Stage 4, I'm not discussing here. Now, this is another change that we have brought about in our antenatal protocols, because we do the 12-week scan, we do the 20-week scan, but there is still no consensus on the 36-week scan. But most of the countries which are high resource have now shifted to doing a routine 36-week scan, and most of the good centers with high resources also do it. So we have made it our protocol also. We gave a study thesis on it, and we found that when we are doing a routine third trimester ultrasonography in the so-called low risk population, we found that out of 260 women that were analyzed who are so-called low risk, there is nothing, not even anemia in them. So 47.5% had no identifiable risk factors, and 52.5% had at least one abnormal parameter. Abnormal means either the estimated fetal weight was less, or the AFI was less, or one of the Doppler parameters was abnormal. So, any one of the composite ultrasound findings abnormal in these so-called low-risk women, sensitivity was highest, and specificity, diagnostic accuracy were highest for the CPR. So, Madam Chinmay, Madam showed a very beautiful graph on how actually for the late onset FGR, CPR is very important. So, we found that a lot of our women, they have babies with undiagnosed FGR, and 52%, more than half of the women who are so-called low risk with no gestational diabetes or hypertension or so-called FGR diagnosed before, they have at least one abnormal ultrasound parameter which is correlating with an adverse outcome. So we have changed protocols. We now offer routine third trimester ultrasound. This we have been doing for a long time now, couple of years, 3-4 years, and it has improved our outcomes a lot. We've even got people who are coming for the first time, and they are having at term 38, 39 weeks, and they are having absent flows, and they straight away go for induction and short trial and delivery. So this was about most of the cases that we get. Also, twin gestations. I have not included all the multifetal because twins are most common, which is 8%, 10% of our stillbirths. So it's very important that we optimize outcomes even there. So identify and give the chorionicity in the first trimester itself. It is often told, but still we have patients also telling that only twin hai. They do not know ki chorionicity kya hai, mono hai ki di hai. They do not know, which we need to tell our patients that this is the kind of thing, kind of twin that you have. And based on the chorionicity, the antenatal management differs. So this we have pasted it in our OPD so that each of our resident, because we have new interns coming every month, so there's somebody new coming in every month also. So that everybody is on the same page. We know that, okay, if there is a twin gestation, we need to know the chorionicity, and these are the things that we need to do depending on whether she's having dichorionic or she's having monochorionic pregnancies. And then it comes to the consultant and follow-ups are done. So these things help in preventing, giving them good outcomes and help in preventing adverse outcomes. We've had this kind also a trap sequence which was reported as a tumor which was growing, and when she came we realized no, it's not a tumor. And then at that point of time when she delivered and we told her that okay, this is what will be happening and this is this trap, so they had no idea, no clue exactly what is it, what happens. And at that point in time even disposal was a problem. Infantogram we do for all, that is available with us. So an autopsy also was done for this case. This was a very sad case where this was an intramural in the sense that she was a booked patient with us in the first trimester, chorionicity etc. established, and then she did not turn up for antenatal checkups. She came at 40-41 weeks and she delivered these twins which were dead. So we asked her what happened, that why she didn't come. So her husband was a construction worker and he had a leg fracture, so he could not bring her. So that is the level of empowerment of our women. It's so sad. She was staying on the campus at that time, some construction still going on, and she could not come because her husband could not bring her. It's hardly a distance of 500 meters. So we need to tell them, that if they do not come, it's not like a normal thing that you keep on waiting for labor and labor will happen. So very important that we teach the women, and probably we should have some way that if they are not able to come, you are able to go to them and find out that what really has happened. So this was very sad in one case which had happened. So to summarize, what is it that we do? Our strategies: preconceptional and first trimester folic acid for all, correct anemia antenatally. Now even the PMSMA team that goes they also, I said that you do a study and you see how many you think are low risk and how many do you think actually come out as high risk, and more than 50% come out as high risk. They even call and ask, ki anemia to sabko hai, to are all high risk? I said, yes, all are high risk and you need to treat each of the anemias. So we need to, really target them and correct those anemias. Not only PPH and other things will improve, even stillbirths will improve. So quality management, it's not just about starting labetalol, it's also about delivering on time, to do the labor induction and not to keep on waiting only for spontaneous labor to happen. Same about gestational diabetes. Stage-based management of FGR is very important. It's very important that that is why Shama Madam's initiative is very highly appreciated, that now so many hands are there which will be fighting for the fetus as well as for the mother, that now so many people are trained, and FGR can be diagnosed and managed, because more than 50% would be having some abnormality in ultrasound. Growth scan with CPR we do for all. I am very sure in the next couple of years this is going to come as a recommendation from Ms. Wong. And in twin gestations, adequate antenatal management, not just saying twin, but according to the chorionicity, we do the management. This is something that left a big impression on me, that there is no foot which is too small, that it cannot leave an imprint in this world. So everybody, see the stillbirths, there was a time we were not even counting, but any human life that comes to this world, whether alive or dead, deserves dignity, deserves to have a place, and deserves to know what that it came by, and if it come and couldn't walk, then what was the reason and how that can be prevented. So every pregnancy should have, and this is a slide from one of our visiting professors who came from Stanford, and he's a person from Odisha, and this was his last slide, that whatever you may do, systems awareness, systems design, trainings, etc., they are all there, but they are not enough, because ultimately the secret of good quality is love, because you need to love your subject, you need to love your patients, you need to love your profession to be able to give 100% to it and have good quality. So that's about it from my side. Thank you very much, and thank you, madam, again for giving me this opportunity.
Fantastic, Shweta. You just hit the nail on the head. And love is the solution to all problems on earth, including reducing MMR and IMR in our state. Love our state, love our mothers, love our babies. Love, love, love. That is the only answer. And this will set you working. It will set you doing all the right things, that they are not rocket sciences, and they are not. So, in Abdul Kalam's words, these are his work, which he is doing through small people like us. Okay, thank you, Shweta, very much. Now we come to
thank you, madam.
In fact, your experience is wonderful. We keep it, and in the technical groups, hopefully you will be invited, as well as so that we decide certain things on stillbirths, and we'll be taking you into account. And this presentation of yours, of course, is being recorded, and it is the property now of RRC.
Yes,
So
ma'am,
that,
I'll mail you
that
the
will be
slides
shared
also,
and
no worries.
reshared, so that we come to the reachable goal. Thank you, Shweta, once more.
Thank you,
Now we come
madam.
to
My video is not working. I don't know why, but thank you very much, and my regards to everyone. Thank you.
Thank you. Now we come to Dr. Lata.
Ma'am, no introduction. We'll straight away go to the topic. I'll just share my slides, ma'am. I think it's
Dr.
been
Lata is a professor and head of JIPMER, whose motto is Truth Cures, Satyam Mahabheshajam. And the area is called Dhanvantari Nagar. And they chant Dhanvantari shloka in every event that begins. And it really stirred my heart, my soul, when I heard that shloka in the last perinatal netology conclave. And Lata heads the department, which has been headed by many stalwarts like Asha Umachigi, Rajaram, Professor Rajaram, Professor Habib, Professor, and I've known them all. And so Lata is here. Anyway, we want to share your experience.
Yeah.
JIPMER is always at the forefront of many initiatives for maternal and perinatal health. So we want to know from you what is done at JIPMER for as regards preventing stillbirths or even perinatal deaths? Lata, please share your screen.
Thank you, Dr. Shama. I know you through my teachers, Dr. Reba and Dr. Badrinath.
Yeah, Reba was
I don't know what to talk, because whatever I was to tell everything, and Shweta did such a fantastic job, and Chinmay and everyone. So what I have done is very few slides, just a gist of, I have not gone into details of everything, because I'm sure most of the institutes are following these. I'm just telling what change has happened over past 10 years. That's all I would like to bring in. So these are the slides which everyone has said, 4 stillbirths, and most of them are happening in Southeast Asia and Africa. So this is the goal we have set in, but where we are still 31.2 deaths. So I think this and all, I'll just skip through. 50% are intrapartum stillbirths, though we are still not concentrating. What is most important is the mother who loses the baby and the family. We don't know really what to talk, and she's also, everyone blames her for losing the baby. This is something very sad. Keeping this in mind, I'll just go through our statistics. So this is what we have. Total number of deliveries per month. If you look at it, it's around, I'm talking about 10 years back and now. Am I audible? I just started talking.
Yes, you are quite audible.
Am I audible?
All looking.
You are quite audible, madam. Please.
Yeah. Yeah, thank you. So these were the statistics. If you look at our delivery rates, it's always been about 1,000, except sometimes, which in February, some months it's very lean because of various social things. If you look at the delivery rates, they have not been too high from then. Rather, they have decreased over last 1 year due to various strategies our department has brought in, because we are slowly taking over only high-risk women, all the low, because there's, I don't know about other states, but in Tamil Nadu, every district almost has a medical college. So we thought it's better that we take care of the high-risk women and let the other medical colleges cater for the low-risk women. Of course, they have every right to come to us as and when required, or if they really want to be with us. So the delivery rates have definitely come down. If you look at the stillbirth rates, this is all in percentages. If you look at, this is only stillbirths, I'm not talking about neonatal deaths at all. This is what happened in June and February. If you look at it, it was around 6 to 7 per month. Sometimes it has dropped. And most of the stillbirths which we have is, already IUD has occurred and they have been referred. But if you look at the statistics now, it has significantly reduced. We almost have 1 or 2 stillbirths per month. It's not much. I think that is a significant change we have had. If you look at the causes of stillbirth, again, 10 years back, it is still, unclassified, like Shweta was telling us, it's quite high. And we have hypertensive disorders, we've had congenital malformations, diabetes, pre-viable PROMs. Still, we have unclassified and hypertension as the major cause. But what we have to look at is the number of deaths. Stillbirths, because of these causes, has significantly reduced. So that's what I want to emphasize on. It has significantly reduced. Whatever the causes may remain the same, but the deaths have significantly reduced due to these causes. Now, why this difference in 10 years? I mean, I don't have the statistics 20 or 30 years back. From then onwards, if we talk now, a lot of changes have occurred. I have not taken that into consideration. These are the 4 causes I thought why there is a difference. Patient, the doctor factor, the systems, and the facilities. If you look at the patient factors, Tamil Nadu has an excellent antenatal care system, right from the grassroots level to this. I mean, we should be really proud of it. And most of the women are aware of early warning symptoms. It's maybe because of public media, maybe in the hospitals, maybe awareness in the PHC, sub-center level. Lot of training programs go on for these ASHA workers and people at the grassroots level. And because of these, they tend to seek medical help early. Sometimes it may be too often, but these are the patient factors and the care which has been given by their family members. Family members also understand that yes, pregnant women requires some support, whether it is emotionally, physically, or even nutritionally. All these have improved. I'm not saying 100%, but definitely it has improved over at least 10 to 20 years. Then the systems. Early detection and treatment, I think all of you will agree, has made a significant difference in the management or prevention of stillbirths. Early screening for medical disorders. I mean, all of us screen women in the first visit itself for most of it. And early screening and detection of chromosomal anomalies and abnormalities. Early referral, interdisciplinary management, at least in JIPMA, we have very good. Suppose we find anomalous fetus, which is salvageable, we discuss with the pediatric surgeons, pediatricians, and make sure that, I mean, I'm not saying we do antenatal treatment or surgeries, but at least we are ready to receive the babies and manage it. If at all it's a salvageable baby, the management is like including diaphragmatic hernias and things like that. We always consult the pediatric surgeons and see which are the babies which will really survive after the treatment. So all these have made a difference. Access to ultrasound in primary health centers. Many of the primary health centers do have ultrasound. In fact, in JIPMA, almost for 10 years, we have been having both in urban and rural centers. And another good thing is the availability of ambulance to ship patients. It's not just for antenatal patients. This is for any kind of emergency. And this is, I mean, any given point of time, we may have 2 to 3 patients coming in these kind of ambulances, which are called 108. And I was asking patients about these. They are very well aware. Doctors are not aware. Healthcare professionals are not aware. But these people are aware as to how to utilize this and whom to contact to get these at the time. And it's available 24 hours a day. And all of you will agree that transfusion facilities, blood transfusion, blood products, people willing to donate has really, really made a difference. Of course, from doctor's point of view, more focused. We have maternal and fetal medicine specialists even in our institute. And because of these, we are doing early terminations when there is a warrant of in maternal conditions, and even in PROM. And because of the early detection of anomalies, the terminations are much earlier, even before they're going to the viable stage. This I'm talking about non-salvageable fetuses. So all this has definitely made a difference in bringing down our stillbirth rates. So in JIPMA, earlier we had more antenatal admissions. We used to have lots of flow beds. I'm sure Dr. Shyama must have seen. We used to have good number of low-risk patients. As Shweta said, low risk, nothing, not even an ultrasound we find in, but everyone preferred to come to JIPMA and deliver because we have a good amount of normal deliveries. If you had seen earlier, our NICU had a salvageability rate of 32 weeks and above, because there was constraints for space and both in NICU and also in the maternity ward, and screening for hypertension or any other disorder was sort of limited. We had only eclampsia room, but now what has happened? We have mainly high-risk admissions, better NICU facilities, better salvageability rates. We can even salvage 20. Our survival is almost 52. I would say I've been very modest saying 50%, but many a times we have even 75% survival between 27 to 28 weeks. I'm not talking about anything below that. And we definitely have increased NICU beds and with ventilatory support. So that's made with all 3 levels, and lot of kangaroo mothers care, and whatever principles have to be followed, we are definitely following. Screening for diabetes, in fact, even for hypothyroid disorders in the first visit itself. And first trimester screening for hypertension, I won't say for all patients, but as far as possible, at least we do in the form of dissertation so that many women get screened. And in Tamil Nadu, most of the women do get screened for all these things. So, and of course, we have a dedicated ICU for OG and HDU. We almost have 7 ventilators just for maternal care services. So we don't really manage because anesthetists are across. We have a theater attached to our labor room. So things have become much easier when compared to what we were as, residents managing. Then again, the limited number of scan machines. I'm not saying scan machines is everything. We always need to have the brain between 2 years, but of course, this do make a difference. We did have an ultrasound machine in labor room since 1995, but that was significant then itself. Earlier, screening, as all of you know, it was very expensive, but now majority of the women come with these kind of screening markers so that we can take decisions and counsel women whether we should terminate earlier. As I said earlier, termination of pregnancies mostly in the first and early second trimester. So affordability for genetic screening and because of which early termination after counseling has become very important. Earlier people were not able to afford. Now, because they know there's going to be only a single child or two children, they really want to get screened. Majority, I would say, get screened. They don't mind even if it is, 10,000, 12,000 and things like affordability have definitely increased. Having a fetal medicine specialist, I'm sure it's a boon because we do get lot of referrals and lot of patients with chromosomal abnormalities. And Dr. Mamta is our fetal medicine specialist. She does lot of autopsies and all out of office hours because during office hours, we don't really get time. So she does lot of autopsies and she's doing a very good work, including, intrauterine transmissions and things like that. And other things, as I told, multiple pregnancy, even our strategies have changed as per the guidelines. Of course, sometimes, as Chinmay was telling, everything cannot be evidence-based. We need to do it even by experience and patient-to-patient consideration. And we have monthly meetings where we discuss not just the maternal mortality, stillbirths, and we have perinatal we have perinatal meetings also where the neonatologists come. We discuss various things. This was there earlier. Now it's become more and more robust. We do discuss infection control and we do discuss the cases where we could prevent the mortality, whether it is neonatal mortality or stillbirth mortality. And all these things are also reinforced in PG symposia during rounds and things like that. If you look at it again, screening in recurrent pregnancy losses has become quite common. Earlier, it was very limited, again, because of financial constraints, and we didn't have the facilities in JIPMA to do so. And if we look at the UHC and PHC, I meant urban health center and primary health center, we used to do only clinical examinations, may pick up, may not pick up. Postnatal follow-up was there, but it's only by examination. Subtle problems were not addressed. And there was no dedicated birth companion because of various reasons. But now, yes, wherever indicated, APLA is definitely being ruled out. We are starting aspirin and heparin as and when indicated. As I said earlier, we do have an ultrasound in both the health centers, and our senior residents are trained for detecting fetal growth restriction. They do a lot of scans even in our institute. So they go there, and every week we have an antenatal clinic in the health centers, both in primary and health. So wherever they detect, they either refer to our institute or any medical college wherever the patient would like to go. We have 8 medical colleges in Pondicherry, so that's not a problem at all. And postnatal follow-up again is done. Sometimes we even call up the patient. We have some programs going on, some studies going on where they're calling up the patients to, especially with hypertension, diabetes, to see what all has happened to them, and so that we can avoid these things in subsequent pregnancies. Of course, encouragement of birth companion to all. We allow only women, not men, because we don't have, separate labor rooms. It's only a screen. But that is okay. Majority of the women like, but some women are scared of coming inside. But that has definitely made a difference. During COVID, we restricted, but yes, we've taken. When I was, Chinmay was telling about decreased fetal movements, of course, it depends on the risk, whether we have any maternal factors identified, past dates or fetal growth restriction. Otherwise, usually we ask the patient to monitor her movements. We have CTG. As I said, we have labor, in both the labor rooms, we have an ultrasound. We have an ultrasound even in our casualties. So a lot of these things are detected earlier. But again, when we talk about CTG, in labor room, we have each of the cords connected with the CTG machine, but sometimes I feel it's more of a bane rather than boon, because we tend to do more of cesarean sections. That happens sometimes. Okay, and as I said, we have regular audits in place, perinatal mortality review. Another thing is introduction of magnesium sulfate for neuroprotection over years has definitely made a significant difference. We have monthly HSCC reports for the entire hospital, every ward, every ICU, labor room. So though we are way below, unlike NIC has the best HICC reports. They maintain everything hygiene very well, hand hygiene. So that has definitely made a difference. And of course, we have dedicated labor room dress and things, labor room slippers. They have to change each, and I keep an audit on that definitely. So, and the change in antibiotic policies does happen every 5 years. People look at the antibiotic policies, antibiotic resistance, and all that. So, all this has made a difference for us. We give antibiotic prophylaxis for all cesarean sections. I'm also talking about preventing of neonatal deaths because of this. So I will just stop here to summarize. Still long way to go. Could achieve reduced stillbirth rates because of early screening and intervention both for mother and fetus. Of course, of better facilities, both what JIPMA had maybe 15 years back and now it has definitely made a sea of change and affordability by the patients. Thank you for this opportunity, and I just wanted to bring in the gist of what we are doing. Many more, maybe I have not added here. Thank you, Dr. Shyama.
Thank you very much, Dr. Lata. We have learned a lot from your presentation. It is very useful inputs for us. And JIPMER is always one of the ideals in the whole of the country as regards its treatment.
I forgot to tell one more thing, ma'am. Yeah. We also have improved what you say, doctor-patient numbers, increased numbers. We have a lot of residents, and also the intake of nurses and other staff has definitely increased. So all that has made a difference, especially in NICU and all. No, almost 1-to-1, I should say. Not ideal, but yes, we are able to manage, at least with doctors. Yes.
So number-wise, we are really in our healthcare setup. We are really a little bit challenging. It's been for us with new medical colleges opening and faculties being transferred. So it's really a big headache for our departmental managers, the head of the department to manage.
Ma'am, but numbers, though they are on paper, I mean, I should not be saying Government of India gives a lot of leave for many people. So that way we have almost 30% to 35% of the nursing staff on leave all the time. So that again, brings down the quality of care.
These challenges are there, but mainly when you have a set of rules where everybody follows, that's the most important thing. And as Chinmay has pointed out, making difference to at least one person goes a long way. And Shweta's message of love as the central thing for achieving anything. So anyway, if anybody wants to ask a question, straight away you can unmute and ask to all the experts here, because Dr. Lata and Dr. Chinmay maybe they would be wanting to, they are quite busy and may be wanting to leave. So first questions to Dr. Lata and Dr. Chinmay and Dr. Shweta. Any questions anybody would like to ask, you can unmute and ask. Otherwise, I will select the questions from the chat box. Yes, anybody?
Hello.
Yes.
I'm Dr. Sodangi from SIH and FW. Probably next to Dr. Hasmukhlal, I am the senior most, including my teacher, Dr. Shama Kanungo. I have a small suggestion rather a question. The beautiful presentations, the recommendations are made. 1-2 suggestions are, our SAP training booklets, they were designed at around 2010 by Government of India. Similarly, the BMOC training book that was designed in 2013. Over the years, it needs to be reviewed and rewritten, and new things need to be inducted into that training program. So it is my small suggestion. Can a recommendation be made to Government of India to induct all these things? Number 1. Number 2, the depressive psychosis. The depressive psychosis following and the fetal demise, the psychotic problem and the aftermath of the events, that the family members will curse her that you are something like a ghost or something like this thing. It is a tremendous trauma on the psyche of the lady, and so that she will fear in future to have a pregnancy again. So these things need be addressed. I am very much having a silent praise to Dr. Sweta. I do not know since when he is there at AIMS. One baby of birth weight 460 grams was salvaged, and she is now 3 years old. So I am having every praise to Dr. Sweta. And
Sir,
regarding
thank
the
you very
present,
much. I'm there for 10 years now and more than 10 years
yes,
now
yes,
at
yes,
AIMS Bhubaneswar.
yes, yes,
And our
yes.
NICU is excellent. 25
Okay,
weekers,
okay. So
routinely
beautiful to
free of
watch the.
cost, they can salvage.
Okay,
3 months they
okay.
keep the babies.
So
And
nice of you.
mothers
So
also we
nice.
have to keep for 3 months.
So nice of you. She stayed for 3 years, 3 months, and that girl is now 3 years old.
Okay, excellent.
Excellent. Now, one suggestion that I have made in the chat box that was not answered. Can this antenatal corticosteroid be administered to the expectant ladies who are GDM cases?
Yes,
Because fetal
definitely.
long maturity is delayed as late as 30 to 39 weeks. So even if they are born after 37 weeks, they are likely to develop birth asphyxia. So it is my small suggestion. Can anybody, because I am not a
So I would
luminary
like to
that.
answer for this. See,
Please.
any corticosteroids are not a routine to be administered to any patient, who have medical problems. But yes, those women who are likely to deliver, and you think they're going to deliver before 34 weeks, definitely we are giving. Diabetes is not a contraindication. Only thing is she may require the amount of hypoglycemic agent she's taking may be given at a higher rate. No studies recommend that you give weeks even in diabetes, but 34 to 36 weeks is a gray area. Some of us still believe maybe we should give because, as you said, fetal lung maturity is sort of delayed in this thing. But before 34 weeks, definitely yes, in case patient is going to deliver, but not as a routine for every woman who has a medical disorder. That much I would like to say. Chinmay can add to it if she wants to say something.
No, I agree, madam, with that it is not a routine indication, but I think what sir is asking is diabetes a contraindication in
No,
itself?
no,
No,
no.
it is
No,
not a
no.
contraindication.
That is
The
not
other
my
thing he is
question.
asking is whether, because it is delayed, the lung maturity is delayed. So even if we are delivering at 38, 39 weeks, should we give at that point?
Yes,
So
yes.
sir, after 36 weeks, right now the evidence is extremely poor, and we don't recommend after 36 weeks for anyone. But before 36 weeks, between 34 and 36, like Dr. Lata said, that will be a considered decision. Because sir, in diabetes, it's a double-edged sword, because once you give the corticosteroid, there is hyperglycemia. And the hyperglycemia is the effect of the steroid. So there has to be a very tight insulin schedule at that point. She has to be admitted and given that. So the pros and cons have to be weighed, but not later than 36 weeks, sir.
Okay,
It is not
nice of you.
recommended. Yes.
Nice of you, madam. Thank you.
Thank you.
Thank you, everybody.
Okay, any more questions directly or from the chat box? I can see.
But ma'am, I
Somebody
think
has
what
asked.
sir highlighted, that is also a very, very important aspect of the aftercare of stillbirth. Like we undertook the investigation of stillbirth, we undertook the causes of stillbirth, we undertook a lot of care to predict and prevent. But once the stillbirth has happened, this is again, every stillbirth is a risk factor for the next stillbirth, because previous stillbirth, like preterm delivery, previous stillbirth is another risk factor. So for this woman, there can be a element of stigmatization. There can be an element of psychiatric, psychological problems, including a bit of abuse also, the way sir pointed out right now. So I think there has to be a leaflet to the parent, to the family as such, that this is a clinically known entity, and the woman herself is not responsible for this kind of a situation. And in addition to all medical issues, she also needs a lot of care and counseling. Then there can be an element of postpartum depression. And luckily in India, we have good family care, because of which people don't go to the extreme conditions like suicide. But this is very much a risk factor for perinatal mental problems.
Yes, madam. Thank you.
I have a question for Dr. Chinmay. You didn't say anything about ductus venosus in decision making. So that I think it was not there in your talk. But of course, I know that ductus is very difficult. Not everyone can, not many centers will be able to obtain that. Yeah.
I did mention the ductus venosus, but the timing when the ductus venosus is the decision maker for delivery is usually around 26 to 28 weeks when we stillbirths per se. Yes, sir. So that is that group of stillbirths which we cannot actually prevent, even if we want to. Like many of them might be able to, like Shweta said, that's an excellent service that Odisha is having in AIMS. But how many people can actually reach AIMS? So if it is a 4 or 5 month fetus, if it is something where you're seeing a ductus abnormality at 22 weeks, 24 weeks, you can predict that stillbirth, but to prevent it will be very difficult. Whereas once we have reached the time frame of 28, 29, 30 and thereafter, we generally are not waiting till the ductus abnormality, because again, the ductus abnormality is high level of acidosis at that point. And when we are trying to prevent, we are not only trying to prevent a stillbirth, we are also trying to prevent a birth with neurological disability. Since it was stillbirths, today we concentrated on the stillbirth aspect of it. But sir, when we are trying to plan a delivery in a baby with abnormal Dopplers, we want to intervene at a time when acidosis has not yet set in, because that is the risk factor for irreversible hypoxic ischemic encephalopathy. And that is why we will stick to
CTG are almost matching sometimes, CTG
yes, sir.
and
Yes, sir. So the CTG is the trigger for delivery after that point. And that is why that did not come across like what you were expecting. But definitely a ductus venosus has to be done, because that even proves, although we are not going to do it to time the delivery at that time, but that proves that so far the ductus is positive.
College exam center so what would you go by zero diastolic flow in umbilical artery?
Ma'am, as you could see in that stage-based assessment, if we are at 26 to 27 weeks, at that time we are probably waiting till the ductus abnormality. We are probably waiting till the
That was
ductus
very good
abnormality.
slide.
Yes,
A
ma'am.
very good
So,
slide.
if you want, I'll put that picture in the group. Just 1 minute.
That's very good. Please put it.
So at that point, if it is at 26, 27 weeks, then we will wait till the ductus abnormality. But when we are at 30, 32, 34 weeks, at that time, even an absent diastolic flow can trigger the decision for delivery, because ma'am, by that time, most NICUs are comfortable. So when we have an absent diastolic flow, the blood flow has been restricted to the splanchnic circulation, but not to the central circulation. So survival is not a problem, but there might be conditions like necrotizing enterocolitis and all, which might be, higher risk factors. So if she is 30 weeks and your NICU is comfortable with 30 weeks, then they will say, don't give us a very sick baby. You might as well deliver the baby now, because once it becomes sicker, we may not have such a good outcome. So that decision for delivery again has to be a joint decision between the obstetrician and the neonatal team, because there are a lot of stakeholders there. I'm very happy with these outcomes where 460 grammars have gone home. But sir, how many 460 grammars on the whole? So those 1 or 2 cases may be outliers, and we should not be very excited with their outcomes, because we have seen 1.2 kg babies go succumb in the NICU. We have seen even 2 kg babies succumb in the NICU, because physiology is very complex. So at that time, it is important for us to talk to the neonatologist and then see. Dopplers, do all the Dopplers. But when should you deliver? That is a simplistic chart that you go till 34 weeks, and if there is absent diastolic flow, deliver. But at every stage, there is a, little gray zone where you can take a decision to continue for some more time or wait, deliver immediately.
Yeah, it has to be individualized. A word of caution, sir was saying like 28, 29 weeks, just depending on CTG is too scary, because we know they are not very reactive till 32 weeks. So at that time, Dopplers definitely help for us to wait and watch.
Dopplers are our first
Do you
clue,
agree,
and
Chinmay?
I will agree, ma'am, because Dopplers are the first clue. The advantage with Dopplers is you have time. Even if it is a reverse diastolic flow today, you have at least a week's time, so to say. So unless there is a maternal illness in the background. So, ma'am, the ultimate message that we all have to take is look at the case in completion.
Exactly.
Every investigation is only a part of the link. You can't look at one investigation separately and do. So for Dopplers, if you read that latest guideline on Dopplers, it very clearly states that no one Doppler is the trigger for anything. So you have to look at the entire clinical picture. So if the mother is running a blood pressure of 180, 110, even a high resistance in umbilical artery is the intervention to prevent stillbirth, because she is at risk of abruption. When she will abrupt, she will have a ductus abnormality, but then you won't have time to deliver the baby. So your entire assessment as a clinician, let us not forget that all investigations are only there to help us. But we cannot give up on our clinical understanding of the case. There is no taking away that you have to take a history properly. You have to know your background properly. You have to know your team properly. And do not deliver a preterm baby without talking to the neonatologist. Because I saw some, there was a thing that we should look at the CCTV on the warmer to see whether there were signs of life. That will only shift the, your indicator from antenatal to postnatal. But I represent Perinatology Committee of FOXI, and I'm telling you, perinatal health indication is an indication of the nation's progress. So if you have converted a antepartum stillbirth into a fresh new infant death, I don't think we have done service overall. So we should look at the entire picture together and deliver only those babies who are salvageable in that frame of mind, and tell people why. Because there are modifiable factors, there are non-modifiable factors. And there are problems from the implementation level. There are problems at the, service level where we are working as doctors. So even if we do excellent jobs, I don't think any one of us can say we'll never have a stillbirth. The ideal rate is not 0. So we have to just minimize it in the most rational way with optimal use of resources. So I think all this, what Madam also presented, those pain relief methods, why are we not thinking about them? Why is pain relief in labor only turning to an epidural or only turning to an IV injection? So that is a very progressive thought. Similarly, counseling the parent, and we have the support of family. So there was a question about what happens if only the husband has come. Let us start an awareness program where we tell them that, when you come for labor, have a woman attendant with you. Culturally, we are not at that stage where we can allow male attendants into the labor rooms in public hospitals. It is not possible. It will take a long time till we get over that discrimination, which is fine. But we always say that, from now on, prepare that you have a lady attendant with you when you come to the labor room. And that lady attendant also can be given some, at the community level, she can be told these simple things about rubbing her back or giving her some moral support or holding her while she sits down. I don't think this is like huge training. That video can be just circulated in public, madam, whatever you showed us.
And also another thing about birthing, and I mean, this is a little bit away, birthing in the comfortable patient position. Earlier, when patients used to sit up, we lost saying, no, lie down, lie down. But slowly we realized like patient comfort is the best. And whatever. And
is it being done at Jipmer? Delivery position?
Positioning,
are you allowing women
not,
to be?
No, it depends, ma'am. Some women want to sit up, we allow, but it's not a routine thing. Slowly, we are also changing. And I'm not saying we have 100%.
I don't know, ma'am. I don't do hardcore obstetrics, but many times it has been that if you give them the independence, they will move around, they will do everything.
Yes.
At the time of delivery, they somehow lie down.
Yeah, lie down. Actually, this ball where they sit, it's very comfortable. I've made a lot of patients use that. I've bought. They're very fine. But when it comes to this thing, delivery, they lie down. But I had some staff and all who said, madam, can I sit up? And I used to tell them, okay, whichever position you want, whether you want to lie prone, whatever you do. Many of them are happy sitting up. Not like,
giving them that option helps them because they feel better.
Yeah.
I think in labor, a woman likes when she feels she is in control of at least something.
Yes.
And the whole respectful maternity care might not be all that fancy for us. Just the simple thought for us to accept that she is in pain. And if she wants to scream, she's screaming because of that. Most of the time we tell them, don't scream, don't do this, don't do that. So just accepting that we know you are in pain. We know you're doing this because you are in pain. And that changes the whole atmosphere of that labor room.
That's true. That's true.
Anyway, that one we digressed.
Any more questions now? Shall I ask one question to Ajit?
One thing.
Sir, any specific place
want
for
to add-
delivery. Yes, yes.
Kriti madam.
Ritanjali.
Madam, I want to tell that add that
Yes, yes,
in
please,
alternate
please.
position
Ritanjali
in our
Mishra.
ML
मैडम नमस्कार
नमस्कार को
मैडम मोर दुई तीन टा क्वेश्चन अच्छी सजेशन टिके अच्छी कहबी टाइम अच्छी
हाँ हाँ that's what
मैडम
we are
रिसेंटली हमर गोटे आईएफडी पेशेंट आसिला G3P2
speak in English because Lata wouldn't
No, it's
understand
okay.
Odia.
I don't mind. I'll
No,
learn
okay, okay. Ma'am,
Korea.
a patient G3P2
I'm understanding, not a problem.
with G3P2 with proper ANC came at 32 to 34 weeks of pregnancy with IUFD. Term IUFD, it was diagnosed by ultrasound. She came to our hospital. Okay. So she didn't believe that I had an IUFD. She was of some religion. So she didn't believe that I don't believe this is a IUFD. I am feeling the fetal movement or thing, anything. So what I feel, a lot of counseling actually required, and to tell the patient that it is IUFD is also very difficult. Because they usually don't believe. They will again go and do some other ultrasound, then again come back. Madam, see, my baby is moving. You see, ultrasound has given me IUFD, but it has not come. So really, counseling it is not so easy. What I feel is, in some cases, it's very difficult. Some cases they really observe. And at this case, I think the delivery process. Someone came and told me that, madam, that patient is being referred from Tangi, and whether I will make it delivery at here or I will refer to some higher center. So actually, in that case, because it is a sudden IFD in diabetes cases, the doctor should counsel. We should counsel her before ki if there is some problem, we should deliver at a higher center. Because in the mid of the night, she comes to our hospital. Again, she is being referred to another hospital. Really, that referral protocol has what Lucy madam was telling. This is really a difficult part to send the patient in the mid of the night to another hospital because she has come in 108 ambulance. She has already been here. So this case also we have to tell from the beforehand ki these patients should be delivered as Kirti madam told in red card. We should mention the place of delivery which patient should be delivered. One thing. Another thing, because Khordha is very near to AIMS and Capital Hospital, both medical colleges, madam. I will request Shweta madam. She is doing such good works. She should focus at least to SRs if they will allow to come to our hospital once in a month at least. So, once in a week, they will just tell us the different. We can make a. Matlab we can develop our knowledge. We learn something from AIMS people if they know something extra from us. Another thing, madam, about gravidogram. Please, मते कहूँ तो केमती सेटा करिबा मते gravidogram ता exactly केमिति करिबी से process टा कहले I will start at खोर्धा केमिति माने पिला लोकन को केमिति बुझे कि सिपिसे फंडल हाइट मापिबा इन वीक्स ऑफ प्रेगनेंसी सेटा हम बुझिते मैडम केमिति करियो किए प्लॉट करियो पेशेंट लोक प्लॉट करियो मैडम मते के डिटेल कहि दियंतु प्लीज मु भी सेटा बुझी पारुनी
See, gravidogram, I had shown this gravidogram to the direct family welfare. I told him to include it in the MCP card. It should be part and parcel of the MCP card so that it is simply a graph. So every time the woman comes to the antenatal outdoor, number of weeks of gestation, it has the symphysis fundus has to be measured and plotted in the according to the weeks of gestation. Because presently in the only weeks of gestation are written. So one ANM thinks it's 32 weeks, another ANM will think it is 34 weeks, another ANM thinks it will be 32 weeks. So instead of putting it in weeks, just measure the fundus synthesis, which is there in the sub training book. Just measurement is written, but where to plot it, it has not been discussed. So in one of the technical meetings where these things were going to be reprinted, I had pointed out that gravidogram should be included in the MCP card. And also the daily fetal movement count
That
should be
will be very good idea, madam.
But now can we start it in a graph paper also? Can we start?
Yes, I have got the graph paper. I am taking it everywhere. Ranjana Bhandari has got a copy of that.
Madam, it was
Mentors I gave you in the mentorship training.
Mentorship training it was given.
Gravidogram and the daily fetal movement count chart. We have given it to you. You just thought
madam, so
we can take a graph paper and take the people to plot.
Yes. I should have put it in my
Every 4 weekly we can do that.
Huh?
Every 4 weekly, and then in the later period, every 2 weekly we can do it.
After 20 weeks onwards, you just plot
After 20 weeks, 28 weeks onward.
Actually, ଆଉ ଗୋଟେ ଜିନିଷ ମ୍ୟାଡାମ ଆମର ଓପିଡି ରେ ଆପଣ ବାର୍ଥ କମ୍ପାନିଅନ କହୁଛନ୍ତି ଆମେ actually explain ତ କରୁଛୁ ହାଇ ରିସ୍କ କୁ କିନ୍ତୁ ତାକୁ କାଉନସେଲିଂ କରିପାରେ
patient ଦେଖିଲା ବେଳକୁ when you
କରୁଛୁ
see a patient in the OPD, please ask, tell your name to the patient.
Yeah.
Tell her that you are Ritanjali Mishra and ask her name and ask her whether somebody has come with her. Has her mother or mother-in-law or somebody. If nobody has come, you tell her that next time you bring her with you and ask her to tell you 2 names with their mobile numbers so that you put it on the MCP card. These are the people who will be with you in every antenatal visit. And if one of them is absent, the other one can come. So 2 names are important. At least one can come. And you give them the ID card and ask her to wear that ID card when she comes to the antenatal outcome visit. These are very simple things. Just it needs a willpower.
Madam, actually we have started. ଆମେ start କରୁଛୁ madam ଖୋର୍ଦ୍ଧାରେ start କରୁଛୁ.
30 mentors. See, Chinmay and Lata, we have created 30 mentors for 30 districts. And Ritanjali is one of them. Ranjana is one of them. They go down and to implement these things, including ultrasound inputs they give for improving fetal-maternal health and reducing fetal-maternal mortality.
ଆମକୁ ଆମେ actually ଖୋର୍ଦ୍ଧାରେ ଆଉ ଟିକେ ଅଲ୍ଟ୍ରାସାଉଣ୍ଡ ର ଟିକେ ବେଟର ଜିନିଷ ଜାଣିବାକୁ ଚାହୁଁଛୁ ଆଉ ଗୋଟେ ଆମର କଲ୍ପୋସ୍କୋପ କୁହାଯାଇଛି.
Preeti Dubey is there close by. She is very willing to go over and give you those.
ତାଙ୍କୁ contact କରି ସପ୍ତାହରେ ଗୋଟେ ଦିନ ଆସିଲେ ବି ଆମକୁ ଟିକେ ଶିଖେଇ ଦେବେ. ଆଜ୍ଞା.
Dr. Hashmukh Lal is also one of our mentors. So we have a mentor team, one gynecologist, one person with ultrasound capabilities, one managerial team. So 3 in a team are going to every district. So we have 1 round of visits now. Dr. Hashmukh Lal has been one. So you please tell your experience in one of your mentoring visits, Dr. Hashmukh.
Yeah, actually, Rama Manjari is there for Khurda. Rama Manjari Naik.
madam sir si ଆସିଥିଲେ madam ଆସିଥିଲେ ଯେ କିନ୍ତୁ ଆମର ଯୋଉ ସେଇ ଯୋଉ ଅଲ୍ଟ୍ରାସାଉଣ୍ଡ ପୋର୍ଟେବଲ ରେ madam କରି ପାରିଲେନି ମାନେ କହିଲେ ଏଇଟା ହୋଉନି ତାଙ୍କର ସେ ନ ମୁଭମେଣ୍ଟ ଟା ସେ ପୋର୍ଟେବଲ ଅଲ୍ଟ୍ରାସାଉଣ୍ଡ ରେ ସେ କହି ପାରିଲେନି ଯୋଉଟା ତଳେ ଅଛି ଅଲ୍ଟ୍ରାସାଉଣ୍ଡ
stand on ultrasound ନାହିଁ କି?
Do you have only one ultrasound
machine? ଆମେ ସେଟା ହ୍ୟାଣ୍ଡଲ କରନୁ because we are not registered with that. Only radiologist has been registered.
So portable can be registered done by us.
ଆମେ emergency ରେ କରୁଛୁ
those who are not registered cannot do that also.
but we are doing emergency madam.
Ritanjali, here is the gravidogram. Here is the gravidogram.
मैडम ମୁଁ ସେଟା ଦେଖିଛି ଯେ ମୁଁ ଏବେ ଯୋଉ କରିବାକୁ ଚାହୁଁଛି ପ୍ରାକ୍ଟିକାଲି କେମିତି କରିବି ସେଇଟା ପଚାରୁଥିଲି madam.
8 weeks of gestation. It is height in centimeter. You just take the week of gestation and plot in the graph. So from 10th to 90th percentile, if the plot is going within those 2 lines, then the baby is growing normally. That's all.
मैडम ସେଇଟା ଆମେ ओपीडी ରେ ହିଁ କରି परिबा ना ଆମେ निजे हेल्थ केयर पर्सनल करिवो ना.
Let the state print it. Let the state print it. All of you give your advice to the Director Family Welfare to print this for the state. You can
better in MCP card only. Better in MCP card.
Daily fetal movement count in 3 rows. Okay, morning, after breakfast, in lunch, after lunch, and after dinner. So it is in one card.
Madam, both should be done in the MCP card, madam. Yeah.
Dr. Lucidas, Dr. Abhay Patnaik, you are here. Please tell your friend, Professor Dr. Vijay Panigrahi, before he retires, include this in the MCP card.
One more thing to be included in the MCP card, madam.
MCP card le pure dele enough. How darkar nahi. No, don't need to print
one
even.
more thing. Along with all this,
if this is given, then automatically we'll have the results.
Madam, बार कंपनी अभी एमसीपी कार्ड लिखि दियंतो मैडम.
हां मु कहिछि तो
बार कंपनी हम भी लिखि देले तार पॉइंट गुडा हम टिक मार देबा.
मैं टिक तम सांगो को कोन.
Madam, also you have to include one simplified patogram in the MCP card.
Why?
So that every person.
No, patogram not. Patogram is only delivery. Patogram is
there in
only
the
delivery.
delivery sheet.
Patient thing.
But
Why
when
should
the
it be there in the MCP card? It is
so
in the
accompanying
delivery sheet.
person, no, accompanying person should see that patogram, and accordingly for every
You're right.
yes.
You have a point there. If you can print a photograph with normal progress of labor and
Yes.
the birth companion sees it, then she will be happy. I should know what this is to be done with my daughter or daughter-in-law.
But not in the
Right. My
antenatal
point is
card.
that
Not in the
No,
antenatal
not
card.
in the antenatal card, madam. It is not in
why
the
not?
antenatal card.
Why not? Why not?
It is included in
It's
the
a
delivery sheet.
confusion,
For
sir.
referral,
Confusion.
we have a
So that-
photograph. We can
so
always give while referral. Na? We have that in the case sheet, safe childhood checklist.
No,
We
no,
can
when
send
you are
that
referring,
photograph.
when you are referring, there also you are giving that MCP card along with that person or not?
No, but photograph
will be-
is
it will be
not.
an
This is
integral part.
antenatal. This is antenatal,
no,
never
not in-
intranatal.
Photograph is an event in labor. So why should
Labor.
it be included in the antenatal card?
MCP card is antenatal, postnatal, not intranatal.
Excuse me, can I leave, ma'am? I have some work to do.
Yes, yes,
Is
yes.
it okay?
Thank you very much,
Okay, ma'am.
Dr. Lata.
Thank you, ma'am.
Any
Thank you
last
for the
message to
opportunity.
Dr. Lata before she leaves? But we are keeping your presentation as our property now. Learn and relearn from that.
It's all out of experience,
Very,
ma'am.
very
Except
much.
the
Thank you very
statistics,
much.
nothing from anywhere. Just out of what really happened these years.
No,
That's
no,
it.
we got an idea of what actually is done at JIPMER and the spirit in which you people do. So that spirit is what we have to imbibe. That's why we called you down to this very underdeveloped.
And she has to come again and again. She has to come.
Yes, yes,
She has to, you have to promise.
Okay, sure, ma'am. Sure. Nice to be part of all of you. I've learned little bit Oriya also today.
Thank you.
No. One word is there. No, when you say bye, something is there. I forgot. So bye in Oriya.
Bye.
No, bye.
Asuchu, ame asuchu.
Not
Asuchu,
Asu.
asuchu.
Bye. Should I go? We'll leave something like that is there anyway.
No, ଆଉ ଥରେ ଭେଟିବା ଆପଣ କହନ୍ତୁ ଆଉ ଥରେ ଭେଟିବା
We will meet again. Chalo. Oh, madam.
Bye.
Namaskar.
Bye, Chinmay. Bye, ma'am. Bye.
Okay. Now, a question to Dr. Ajit. Where should you deliver an IUFD case? Dr. Ajit Naik. Should you deliver an IUFD in presence of others who are having live births, or should you deliver in a separate place? Ajit?
हमारा हो गला ना आप अच्छा से खाइए आपका सब कुछ ठीक है.
He's left, huh? Ajit was there? So, can Shweta, Chinmay tell us, or Ranjana? Where should
we have only one place, madam. So all IFD have to be delivered in the labor room only.
So you have
or where else?
Others will have a live baby. You will have a dead
You
baby.
can have a separate facility. You can have a separate cubicle for that.
So yes,
we can have.
That is, I think, sir, a sensitive thing that the unit within themselves have to understand. And I think in general, we have to increase our sensitivity towards our patients. And when we see that this lady is having an IUD, we can put her in the last cubicle. That is where she will not completely interact with the other babies and not hear the other babies cry when they are born, because it's a very difficult decision. Honestly, sir, if there is a room which is free, like even your eclampsia room, if it is free or something like that, one can make an individual unit based one-day decision that today put that woman there where she will deliver, where other people won't be delivering. But very difficult to make a
very difficult, madam, very difficult.
This is the same problem which is there with antenatal care or OPDs for recurrent pregnancy loss patients. You know, when they come to the gynae OPD, it is said that the infertility and the recurrent pregnancy loss patient should not come to the same OPD where other pregnant women are there. It is psychologically taxing. But I think that's a matter of...
My suggestion is in the same labor room, there should be a special corner.
So you can't sir, you cannot have a corner written as IUD delivery corner.
No,
Nobody will accept it.
Not IUD, but a special corner for other types of deliveries, not only IUD.
I don't think we can label it, sir. It will be superstitious to label it like that. But every day you can make a decision. I
Measurement
mean,
take it.
if you know
Yeah,
somebody
it
is
is not
coming
so
and that
frequently. We are not coming across such cases so frequently. Very
That's
rarely we
yes.
true.
come
That's
across.
true. In
So
a
one
month,
more
about 7 to 8 cases.
one question which should stir our conscience. Actually, there is no punitive action. Why should stillbirth rates, why should early neonatal deaths be included? Because we have found that early neonatal deaths, or even after 1 or 2 hours, if a baby has died after delivery, they are included in stillbirths because there will be no inquiry after that. So this should not be. How to reduce this kind of practice in our setup? Maybe this practice is actually giving high stillbirth rates in Odisha.
It is again very tricky, madam, because some of them
yes.
some of them will happen because they may be undetected cardiac conditions, because a lot of duct dependent conditions will be like that, which will present as live births collapsing within a few hours of birth. So that will be difficult to, unless we do a proper autopsy in every case, we find out the exact cause, it will be very difficult to allocate, sir. That is why
Just
they have
like
put it as stillbirths.
in JIPMER, they are detecting it very early and eliminating, so that these cases are not coming for this stillbirths. But we are very much lacking about the early detection and elimination. That's
So
why
that is
Sanjay
difficult.
Sai says you have to have a CC camera in the birth baby hormone.
So that it
It's
will
not
be
allowed.
known, so that it will be
CCTV is
known
not
that
allowed
the
in the labor room.
so
Sir,
that
it is,
condition of the baby at
you
birth
know,
can be known.
no, we have to, at some point, sir, we
What
all have to
madam's
stand up.
concern is, no, madam's concern is some babies are alive, but later on they are declared
No, sir.
stillborn. If
I think
we will
now,
have that
no,
something recorded, the life events at the birth, that cannot
no,
be.
sir.
Why?
We are clinicians. We have to stand up for our integrity. We cannot say that it was live and it was put at stillbirth. Or we are
That
clinicians. What we say is whatever is the condition. That is it.
That is understood. But for the audit purpose, this is one thing we can do. Before
I don't think we can give them
it is better that you tell the patient in a very polite way that there is something wrong, your baby is not looking good. And I generally go very slowly and tell them, look, the baby's heart is not okay, it is not beating. And then they don't understand that, okay, it is dead yet. So after the scan is over, when we go out, then I call the relative, if there is her husband or any of the people who are there with them. And there we declare that, okay, this is not salvageable. Something is really not gone well, and the baby is not alive. That is how slowly you just don't abruptly say, oh, your baby is dead and not on the table. Don't tell them on the table.
No, sir, not that is not an issue. Issue is whether a live baby who is dying so early will put it in the reporting in the stillbirth or in the live birth. That is the problem.
Baby has taken breath after delivery, but died after half an hour to 1 hour. Should we include in the early neonatal death register or in the stillbirth?
No, once it is out, once it is out of the uterus, it can't be stillbirth. Once it is out of the uterus,
no, it
as
cannot
per
be
live birth.
See, as per
It is a live birth.
Definition, it should be it should be recorded in the live birth.
It is
early neonatal.
It has to be referred in the early neonatal register.
Yeah,
right.
As
This
Saroj
has to
Pandey
be
had mentioned, it is the birth companion who is a witness to this. Whether the baby was born dead
no,
or
madam,
with the
this
baby.
is not so simple, because if this is the situation and all the departments are vying for their statistics, it may encourage delivery of babies who will anyway have an infant death at a time, just so that we don't have it as a stillbirth. So between departments, it will just be a shifting of statistics. Ultimately, there won't be a take-home baby. So I think we need to look at this differently, and we need to have inputs from people
Madam, may I just
who will
come
be
in?
making.
Shama madam.
Yeah,
Yes,
Shweta. Yes.
Yes, definitely.
See, in these cases, nobody wants to own up. Suppose you have the luxury of having a pediatrician or a neonatologist. Nobody wants to own up. They'll always say that early neonatal deaths is, that obstetric problem. But honesty is always the best policy. If the baby shows signs of
Best
life at
policy.
birth, baby is alive, then we cannot, it is, it is not right that
That
we
is
put
true.
that baby as a stillbirth.
Uh,
I think in some trainings in NRP, because NRP now new trainings have also come up, which I recently took in October. So that neonatal resuscitation program by the Indian Association of Pediatricians. So in the new
now
NRP,
it's
they
a
show
new,
you a,
yeah,
yeah, just let me complete. So in this
yeah.
NRP video, they show you a video where the baby in Africa was left for dead, and then the team reaches, resuscitates, and what was taken as dead becomes alive. So many babies without heart disease also, depending on how and where and the condition intrauterine, they may actually have been left for dead, and then the resuscitation saves them. It's so we cannot leave them as dead. Only thing
Yeah,
is
yeah,
that
true.
whether when it is in that gray zone, then whether it is DNR and all those things are there, do not resuscitate. But otherwise, even if we feel they will not live, resuscitation is given. So how can we label them as stillbirths? It is not correct. As doctors, it is unethical if we write it as stillbirths. We don't. It is an early
Exactly.
neonatal death, and let us find out cause for it. Let government start doing
Exactly.
autopsies for it. Let us have systems for it. But let us not start lying about it. I think that's not correct.
Exactly.
That's
That's
all.
Exactly.
correct. Hmm.
Yes, what do you say to this, Ranjana?
No, even
Ranjana?
madam, we don't write. Madam, in new NSSK training, it's told that 20 minutes we have to see the baby. If 20 minutes the baby doesn't respire, no breathing, then and no heartbeat, then only you can say it is yeah, dead.
Stillbirth.
So, say. So that is correct, madam.
That's right.
Madam, one more thing I wanted to ask Dr. Shweta, neuroprotection for preterm. Mane, is it 1 gram in per hour for 24 hours?
Magnesium
No,
Or
sulfate,
no,
it
we
what
is
give it
two?
like what was
dose for neuroprotection? Chinmay?
we give it
Yeah,
as
for
a 4 gram IV stat followed
Yes.
by 1 gram per hour for 12 to 24 hours, depending on
when is the
when you want to
anticipated
deliver
delivery?
and when your NICU bed is available. Minimum 4 gram per hour followed by 1 gram per hour for at least 12 hours, preferably 24 hours.
At least 4 hours is also okay. I mean, minimum
Yeah,
4 hours it should
anything
be
is
in the
better
system.
than nothing.
Exactly.
So if
So
you just, if 4 grams is given IV, and then patient is referred to a hair center, in between 1 gram per hour is not
that drip,
possible.
the that drip can be put and sent, no, ma'am.
Huh?
Put it
The
in the
drip
IV
can
line.
be
Itself,
put
if
and
they
sent. The
run
IV,
very
it's
fast,
an
also it's a problem.
This
But you
information
should
has
be
to be
referring those
given to
babies before
uh,
actually MACSELF has been required. No, let them reach
and
to the
also
center and give.
suppose no, Dr. Shweta, suppose they are referred when they come into the maternity unit, they are not going to be delivered immediately, isn't it? So
Yeah,
that has to be part
exactly.
of the referral program. As soon as they are received in the referral unit, the drip should be restarted. At least the loading dose you can
No,
give there, and then
problem
the
with
drip
drip is that most of the centers do not have these infusion
infusion
pumps,
pumps.
and
Mm,
running it in
mm.
normal saline drip and all that manual drip
risky.
is very dangerous. So you can give 4 gram IV and then refer along with the steroid dose and all
But
maybe.
madam,
But
from Shama madam, from an implementation point of view, if you are going to take care of such small babies and such critical babies, then availability of infusion pump should not be the limiting factor, right?
Yes, point taken.
hardly it is available in the state, infusion pumps, hardly available.
I
Hardly
You
think
ask how
available.
many people have, it's not available.
No,
so.
no,
In
And
it's
this
then
not
running
available.
forum,
MACSELF is very problematic.
So what
so
to
I
do?
think that's a recommendation to
Give
make
4
that
gram
we must have.
IV, give the first dose of steroid, refer.
Acha.
What about an intramuscular injection? Wouldn't that last longer than an IV?
But the
Ma'am,
whole role is
usually
to
for
give that
neuroprotection, usually our neonatologist tells to give this IV dose only, which
IV
we've been
only, ma'am.
following for many years now. Yes.
The
IV 4
dosage
gram
is
in
exactly
dilution, 100 200 ml normal saline is very simple to give over 2-3 minutes or 3-4 minutes. That's fine.
So every
No
hour you
side
can't
effects
What
give
happen.
about
every hourly.
eclampsia? What about an eclampsia patient who gets full 14 grams of Paxil?
Yes, so 4 gram is
4
very
grams
low
through
dose.
IV and
No, that is
Nothing,
true, ma'am.
no
But the
side
studies,
effects happen usually.
no. What Shama madam is saying is true, but that is given for the maternal effect on the maternal brain, isn't it?
It
But
also
when
have
we are
effect on
giving it,
the neuro.
when we are giving for fetal neuroprotection, we want it in a concentration that is directly going into the fetal unit. So IV and at that doses, though that is the studies that have been done, madam. The rest of it will be difficult to recreate because again you are giving a very high dose to the mother in anticipation that it will reach the baby. So those kind of studies will be difficult to conduct also.
So only 4 gram IV we should give.
4 gram
And
IV
1
over
gram
10-15 minutes and followed by 1 gram per hour
1 gram
infusion
per
for
hour.
at least 4 hours or 12 to 24 hours, like she said. If the delivery goes beyond 24 hours, then you have to reassess, maybe stop. I mean, that's why you should not start it if you're not anticipating delivery within the next 24 hours.
Thank
Very
you.
important.
My video is not working.
I think we've started quite long and we had a lot of very, very important inputs from our experts. Thank you so much from Odisha, from the Center of Excellence for Maternal Health. Thank you, everybody. Thank you, Chinmay. And
Thank you, ma'am.
and thank all the mentors who have been joining here, Shweta and all the participants. We'll keep in touch, and there's a request from UNICEF to share your PPTs so that we can keep it for future reference. Can you give your PPTs to my WhatsApp ID so that I'll ask Lata, she's left. So all the participants, please share your PPTs so that it will be useful for future reference when we use it for further, maybe in our mentors interactions later on, the second round. So thank you very much. And
Thank you. Thank you.
मैडम बारंबार आसंतु टिके आसंतु अम्मन को टिके आहुरी इन्फ्यूजन दरकार.
Anytime. It is very inspiring for me also.
It was a great learning today, refreshing the learning process. Dr. Chinmay.
Yes, about ductal stenosis, I learned that it's after how many weeks did you say? 30 weeks, ductal stenosis.
She always leaves a very clear message. Yes, they always.
Yes.
I think
because I was of the
anybody
opinion
would
that ductal stenosis has to be
26 weeks. 26 weeks is ductus venosus. Reverse diastolic hela 30 weeks. Absent diastolic hela 34 weeks and 37 weeks for other CPR.
Actually umbilical artery jodi apna early FGR re jodi jete earlier apna umbilical artery changes dekhibe se setiki shighra deteriorate karibo. There is a specified time, you know. But let us say if you are finding abnormal umbilical, then that fetus will by 20, 30 weeks tar mane severe MCA changes asijibo. So these are some, I think we have to learn a lot from Dr. Chinmay. She has a it always leaves an imprint on our memory. And even Dr. Shweta had a great, so Dr.
Dr. Shweta's data is very good. Dr. Shweta's data is very encouraging.
For your information and for
Yes,
all
ma'am.
those who have still not left, in the next round of webinars, we will be having interaction with Professor Sultan
and Dr. Rani Thakkar,
perineal injuries. On perineal injuries and episiotomy. So it's something.
More tige rahuchi. Namaskar. More patient asanti bahare sabu.
Thank you very much.
My patients are namaskar.
Thank you, madam. Thank you, sir.
Namaskar, sir.
Ranjana, madam. Bye.
Shweta, thank you, madam. Thank you.
Hemant sir, are you the host? Hemant sir, are you the host? Or Sambit, who is the host? Can you call the meeting to an end? Or shall we leave straight away? Hello, who's the host? Hello, Hemant sir. Dr. Hemant.
Shama madam, you are only the co-host. आप बंद कर सकते हो.
Okay. So, au revoir. Thank you. We'll meet again.
Au revoir.
Thank you very much. Merci beaucoup.
Bye.
Have a come.
Thank you, ma'am.